Your voice is muted. Not ours.
No sound. Control alternative to
Okay, what?
Somebody say voice is muted. It's there. No, there's a phone.
Is showing control or
Sometimes from the sometimes took live picture also a person who came for the surgery. So they find that time it was smoke versus clean.
जीवाधिनायका सर्वेश्वरा. Thank you all. Now we move on to the inaugural session of this international hybrid seminar. I would like to invite Dr. K.P. Ramesh Kumar, Principal Scientist at the Phytochemistry and Phytopharmacology Division of Jawaharlal Nehru Tropical Botanical Garden and Research Institute, Palod, and General Secretary of Kerala Academy of Sciences to deliver the welcome address. Welcome you, sir.
Thank you. Respected dignitaries, Professor Dr. H. Venkateswarlu, Honorable Vice Chancellor, Central University of Kasaragod, Sri M.C. Dattan Sir, Padma Shri Awardee, Scientific Mentor to Chief Minister Kerala, Professor Dr. G.M. Nair Sir, President Kerala Academy of Sciences, other dignitaries, faculty, dear students. A very warm good morning to all and welcome to this international webinar on emerging infectious diseases, molecular diagnostics, vaccines, and future medicines. It's my proud privilege as the General Secretary of Kerala Academy of Sciences to welcome you all to this program. So as you know, we are all passing through a difficult situation of the pandemic COVID-19. And though a little bit it has been alleviated recently, even in today's newspaper, there was a news that new variants of this SARS coronavirus 2 is emerging, especially in South Korea and China, and restrictions are going to continue over there. So still we are under the threat from such pandemics, emerging and re-emerging pandemic diseases, infectious diseases particularly. And the interesting point is that science and technology has emerged as the only way forward in this difficult situation. And at every corner of this globe, in-depth scientific activities are going on to curtail the difficult side effects of these pandemics, and also to face the upcoming such difficult situations in future as well. Indeed, the humankind is indebted to the activities of such great scientists going on all over the world. However, there exists a gap in assimilating as well as disseminating the information gathered and the knowledge generated, especially with regard to such scientific achievements. And there lies the importance of science academies like Kerala Academy of Sciences. Kerala Academy of Sciences is a premier professional body of scientists, academicians, and technicians in Kerala engaged in science popularization. We are organizing several such programs across the state towards the goal of science dissemination of recent developments in science and technology activities, science popularization, and so on. So I'm proud to mention that the Academy has grown beyond the limits of state boundaries to national as well as international levels, as we are organizing regularly several such international programs by inviting stalwarts in the field of various aspects of science and technology. So it's a proud privilege for me to welcome you all to this August function. First of all, we have with us today Professor Dr. H. Venkateswarlu, Honorable Vice Chancellor, Central University of Kerala. He is an eminent academician and who took the Central University of Kerala to a global standard with the motto of aim high and achieve more. So on behalf of Kerala Academy of Sciences, Daleview College, and one and all assembled over here, I would like to welcome you, sir, to this function. We are much privileged to have with us Sri M. Chandradutan sir, Padma Shri awardee, scientific mentor to the Chief Minister of Kerala. So we all agree that our state, Kerala, has made pioneering progresses, actually by leaps and bounds, especially in the field of science and technology. And the think tank behind these great achievements is nothing but this M. Chandradutan sir. So we are much lucky to have Chandradutan sir to inaugurate this function. So I welcome you, sir, to this function. As I mentioned, Kerala Academy of Sciences is organizing several such programs for science popularization, for disseminating the recent advancements in the field of science and technology. And the Academy is being led by the President, Professor Dr. G.M. Nair. And I welcome you, sir, to this function. I also use this opportunity to welcome other distinguished office bearers as well as executive council members and esteemed members of Kerala Academy of Sciences to this function for attending online as well as offline. So today we have with us Professor Dr. Gagandeep Kang, FRS and Professor of Microbiology, CMC College, Vellore. He's actually a world-renowned scientist and who represents India in several world forums, especially related to the recent pandemic COVID. So welcome you, ma'am, on behalf of Kerala Academy of Sciences, Central University of Kerala, and the Daleville College of Pharmacy and Research Institute. Welcome you, ma'am, to this function. So the Daleville College is emerging as a pioneer in the field of, not only in the field of scientific academic activities, but also in several socially relevant activities. And I use this opportunity to welcome the able management of this Daleville institutions, Mrs. Deena Das, Chairperson, and Dr. Shaiju David Alfi, CEO, and Principal Dr. Manoj Kumar, and other faculty members, as well as the students of this college to this function. So the major attraction of today's program is the invited talk by the leading scientists from all over the world. Actually, we have 5 lectures scheduled today, and we have an array of scientists from across the globe who are the world experts on the topic mentioned, that is emerging infectious diseases, molecular diagnostics, vaccines, and future medicine. So we have with us today Dr. Vinod Skaria from IGIT. Welcome, sir. Dr. Shyam Sharma from Nipper Mohali. Welcome, sir. Dr. Anindya Bhatt from Sri Chitradugal Institute of Medical Science and Technology, Thiruvananthapuram. Welcome, ma'am. Dr. Ruslandy D. Alvis from National University of Singapore Medical School, Singapore. Welcome you, ma'am. And Professor Dr. Linfa Wang, National University of Singapore Medical School. So welcome you also, sir, to this time. So we are also blessed with the presence of Dr. A.G. Sekhu, Principal Scientist at Trivandrum, Dr. Siri Mohan, sir, of the Toxicology Department of International, and Dr. A.G. Pandranga, sir, our former director, JNTBRI.
Nair, a distinguished academician and scientist in the field of plant sciences, has held various positions in the academic field, starting as a reader in botany, University of Kerala, and retired as professor at the
of Botany, Dean of the Faculty of Sciences, University of Kerala. He was former director of KSCSTE, JNTBGRI, Palod, Trivandrum, Dean of Science in Central University of Kerala, Kasaragod. The advisor, Kerala Biotechnology Commission, KCSTE, Pattam, Thiruvananthapuram.
Currently, he is the president of Kerala Academy of Sciences and also the director, Central Laboratory for Instrumentation and Facilitation, University of Kerala, Thiruvananthapuram. Welcome, sir, for the introductory remarks. Welcome you, sir.
Thank you. Respected Professor Dr. H. Venkateswarlu, the Honorable Vice Chancellor of the Central University of Kerala, Kasaragod, respected Padmasri Dr. M.G. Dattan, scientific mentor to the Chief Minister, Government of Kerala, most respected Dr. Gagandeep Khan, the keynote speaker of today's function. We have Mrs. Dina Das, the chairperson of this education institutions of this Daleview. Dr. Ramesh Kumar, the General Secretary of Kerala Academy of Sciences. Dr. Shaiju Alfie David, again a chairman, CEO of this institution. All the distinguished invited speakers, students from Daleview College, members of Kerala Academy of Sciences, fellows of Kerala Academy of Sciences, as well as all the other dignitaries who have joined this August function. Dr. Pandurangan, the former director, my successor at TBJRA, Jawaharlal Nehru Tropical Botanic Garden and Research Institute. My great friend, Professor P.V. Mohanan, Head of Toxicology Division, Srijitra Tirunal Institute of Medical Sciences, and all the other invited members who are attending this program online. Welcome to this great international webinar, hybrid seminar, which is being hosted by the Kerala Academy of Sciences in association with the Daleview College of Pharmacy and Research Center, as well as the Central University of Kerala. At the outset, let me pay my respectful homage to the great visionary, the reformer, the person who has built this empire of institutions in Trivandrum, looking at scientific social responsibility, installing scientific institutions as well as a number of charitable institutions. I'm extremely proud to pay my tribute to three late Kristudas and Mrs. Chandadas, who left us a year back, but leaving a legacy, leaving an institutions, a group of institutions which have great societal relevance and societal impact. Hats off to them for their vision as well as for establishing this institution. Thank you, Sri Kristudas, and thank you, Srimati Shantadas, the founder persons of this institution. For that matter, Kerala Academy of Sciences is very happy that we could hold this meeting here. And I'm sure that in this academic ambience, where we have a number of young minds sitting in front of us, definitely it is taking the vision of Kerala Academy of Sciences forward. As most of you may not be knowing, Dr. Ramesh Kumar has already said about the professional body, which is headquartered in Trivandrum, having got about 700 life members, 13 honorary fellows, like stalwarts like Dr. Kasturi Venkat, Dr. Ayingar, Dr. M.S. Swaminathan, Dr. M.S. Vegetan, Dr. Professor Vijayan, Professor Dr. M.C. Dattan, Dr. Madhavan Nair, G. Madhavan Nair, Dr. Radhakrishnan, Dr. Radhakrishnan Pillai, the former director of TBGRA, Dr. Suresh Das, former executive. So this shows the kind of strength the institution has. The Kerala Academy of Sciences, because we invite stalwarts not only from Kerala, from different parts as honorary fellows. And I'm extremely proud that many of them give their great guidance as well as support to this institution to grow. It has completed 30 years in Trivandrum, in Kerala, in India, as well as globally. It has made it start. We have members, as I said, about 700 members, live members from all over the world. Essentially, Malayalees, Keralites were worked here, and outsiders who worked in Kerala. But even otherwise, we also invite and welcome people from outside the state to become members, because our vision is not to become a regional center, but to go globally, taking science to the students, inculcate scientific temper to the students, taking the great vision of Pandit Jawaharlal Nehru, that the science only can make a country grow. And I'm sure that India is growing because of its scientific strength. You take many spheres of activities, you have the space technology, we are on top. We have the nuclear technology, we are on top. Computer science, information technology, we are almost on top. Biotechnology, we have made great epoch-making impacts. As well as you take any, even now we have the robotics, the artificial intelligence, and sort of new technologies of the fourth industrial revolution to be taken in a great way. We support Kerala Academy of Sciences as a professional body, a political, that we going for making science to be taken to the masses. As we understand in a golden vision that only young minds who come to science can only make people like Vikram Sarabhai, many other great scientists of the country. There are potential people sitting in front of us. Even Nobel laureates, if you make up your mind that if your vision is great and if your dream is high, like Dr. Vijay said, that if the students can dream high, dream great, and he said specifically that dreams are not to be seen while sleeping. It should be something, it should not let you sleep. That should be the kind of determination you have. The young minds, young people sit in front of me. We are there to back you. But we are giving, we are advisors, counseling. We move to different parts of Kerala to reach all the schools in different parts. For that matter, we have organized 30 school meetings where we will have top people talking to them on science, inculcating scientific temper, because we have completed 30 years in Kerala. We have made great services. This seminar, when it was framed, we have invited topmost people from the country as well as the world to speak to you. Mainly because that, as was said by Dr. Ramesh Kumar, for the past 2 years, we have been frozen almost, mobile, confined to our homes and glued to the computers, seeing everything online, no physical interaction, but then luckily that we are just out of the pandemic. Maybe, hopefully, that we will not have another spike coming up, other wave coming up to affect the population. Again, making us to sit at home and watch through the internet all those things happening around the world. But Kerala Academy of Sciences were never compromised. For the past 2 years, we have been on to making science to reach the society. A number of programs have been arranged online. People from all around the world have been invited to do lectures, especially on the pandemic, on the coronavirus, COVID-19, the variants, and all those. Today also we have great personalities like Dr. Ganesh Khan, as well as many other people who have given lectures to speak about the pandemic, their impact, as well as how exactly we have come to gone for a preparedness where we have made vaccines, we have supplied vaccines to the world, the rest of the world, and maybe that even if another wave comes in, we will not be affected. That's the strength and confidence we have. And for that matter, I'm sure that this webinar is going to be an opener to many of you. Please listen to the people, even people who are sitting in front of me, as well as those who are online. Please listen to the great people. And this is what Kerala Academy of Sciences wants. I'm extremely happy that we could organize this in Delhi, a great institution. By seeing the ambience of this institution, the kind of dedication of their minds, beaming faces sitting in front of me. I've been noticing the beaming faces as soon as I walked into this institution. I'm sure that the vision of Sri Krishnadas will be taken by the followers, daughter, his son-in-law, and other people, so that the vision that these great visionaries have will be translated into reality, taken to the mass, because that's what the main important thing that should remember is that science is there. Science makes a lot of impact, but then if it reaches the society, only the science has value. So maybe the scientific social responsibility, every scientist, that's what we do in Kerala Academy of Sciences. We take science to the masses, to the society. We preach to people as well as we act. We facilitate the science to reach the society. Translating the vision of Pandit Jawaharlal Nehru, I'm sure that India will have a great future. We will become the developed nation in short period of time, provided we take our great science to the society, great science to the international arena, and we compete with people with confidence, determination, as well as hard work. I'm extremely happy to be here with you all this morning. We will be interacting with you for the whole day. We will also listen to the people who will speak in the subsequent time, especially Dr. Deventhi Khan and all the other missionaries. So, wish you all the best. On my behalf, from Kerala Academy of Sciences, I welcome each one of you to this webinar. I'm sure that you'll have a wonderful day ahead. Thank you.
Now, we are moving on to the presidential address by Professor Dr. H. Venkateshwarlu, Vice Chancellor, Central University of Kerala, Kasaragod. Professor H. Venkateshwarlu has started his innings of Vice Chancellorship at the Central University of Kerala on August 2020, having previously served as a Professor of Commerce in Osmania University, Hyderabad for 25 years. A marketing management expert by profession, Professor Venkateshwarlu is a recipient of M.Com, MPhil, and PhD degrees with excellent academic track records. Professor Venkateshwarlu's enthusiasm and commitment to teaching won him many accolades, such as Best Teacher Award from the Government of Andhra Pradesh in 2010. He was a recipient of ICSSR Teacher Fellow too. Prerana, a student awareness and motivation program which backed prodigious laurels across Telangana state for 2 decades, is a brainchild of Professor Venkateshwarlu, who believes in student facilitation, motivation, and support. Professor Venkateshwarlu served the prestigious position of the Executive Vice President of the Indian Commerce Association for 9 years and later its President. He was a joint director of the National Academy of Development, Hyderabad. He successfully guided 25 research scholars at the doctoral level and 5 at the MPhil level, and 6 are still working under his supervision for doctorate. He delivered lectures all over the country in about 50 universities. He has a passion for research and contributed 30 research articles in a number of prestigious journals, and also held the position of the editorial advisor to the Indian Journal of Commerce. Professor Venkateshwarlu visited many prestigious universities like Stanford University, Wharton Business School, Princeton University, and San Diego University. Now, the Central University of Kerala is known all over the country as a center of excellence and a highly sought-after educational institution under his leadership. He took the charge of the Vice Chancellor of the Central University of Kerala with a note of declaration that aim high and achieve maximum. We invite you, sir, for the presidential address. Welcome, sir.
Thank you very much for the introduction, the Kerala Academy of Sciences. Am I audible? Am I audible?
Yes, sir.
Okay, thank you. Very good morning to all of you. Greetings from the Central University of Kerala. My congratulations to the Kerala Academy of Sciences and all the science community that is present at the international webinar on emerging infectious diseases, molecular diagnostics, vaccines, and future medicine. So this is a program associating and involving many intellectuals across the world. I'm very happy to see so many stalwarts participating in the program. I see Dr. Vinod from CSIR, Dr. Sham Sharma, Dr. Bhatt, Dr. Ruklanti from Singapore, and then another doctor from Singapore. So it's a great effort, I understand, that the Kerala Academy of Sciences has done. My congratulations to Professor G.M. Nair, who has been my good friend in Kerala for the last 1.5 years since my joining and my stint at the Central University of Kerala, and Dr. Ramesh also. Then I find a very good, interesting designation here in Padma Shri Dattan, a leading space scientist and scientific mentor to the Chief Minister of Kerala. I think this is probably every state requires a scientific mentoring body, maybe not one individual, but a scientific mentoring body to the policy makers, policy implementers is required. I suppose a lot of work is being done by the scientific mentor to propagate science in the state of Kerala. And the General Secretary of Kerala, Shaiju David, CEO, Dale View College of Pharmacy, and many other distinguished participants, faculty, and students of the institution, members, and all other ladies and gentlemen. This is really wonderful that you thought of a very contemporary subject for the webinar. And on this contemporary subject, I have 1 or 2 points. I'm not an expert, I know. Like I'm here in the capacity of Vice Chancellor to be the president of the program, inaugural program. As a student of science, I was a student up to my 11th or 12th standard. And now I am a student of, of all these subjects. Being the Vice Chancellor, we have 10 science departments, and all the 10 science departments I get interacted. Yesterday only I was in biochemistry, trying to understand their needs and the research that they are going to take up. So every science faculty, I interact with them in their room. I go to their chamber and sit with them, and then try to find out what exactly is in store with that particular faculty for the next, say, 6 months or 1 year, and what is required for them. Because as I understand, as a teacher, in every country is interested in human development. Human development is the well-being of a person. And as we look at the human development index of the country, we rank very low, about 130, 131 out of total 190 countries. That is, it is a poor status, independent of the governments, independent of the independence that we have lost 75 years. That is, something is not really good. And, we face so many hurdles. And probably we boast that we have a huge scientific pool, but do we have enough science propagation in the country? Do we have enough science believers? Do we have enough science practitioners? How much of science thought has gone into the masses? There are some people taking science, but how many people they know they really like science? Like when we talk about the latest science that we are talking about, but mostly today, as we see, as I see the trend, most of the people, so today we are talking about data analytics, basic research, what is required for a better human living is the basic original research that is required in both university labs and as well as institutional labs. That is, when we talk about science, it is to attain highest possible level of health. That is medical science. When we are talking, yes, highest possibility of the health that we should be aiming for. And I would like to make a very clear-cut statement of the webinar that what should be the health goals in terms of the statement that you are making, you are discussing today. That is, we are talking about vaccination, you are talking about the safety of the vaccination, you are talking about the diagnostics, you are talking about the future medicine. Can we have, now scientific mentor is there, that's a very interesting thing, that can we, at the end of the seminar, can we have a statement on what are the goals for all these subjects, vaccination goals and other related goals that can be set for 22, 23, 24. And that's where probably the state government and also Indian government should start thinking of probing into expediting, exploring, and then connecting to the best institutions in the world. And what I have been observing here in this pandemic, so we reacted after the pandemic came. That was the issue. There was a time lag. So many millions have died. Now, have we not been, have we been proactive? What is the status of the readiness for any eventuality in the case of disease? So is there, I don't know, I'm not sure. I'm a layman here. Can there be a proactive situation, proactive mechanism whereby there is some kind of arrangement when that we face an emergency situation, and then there is a target, then there is a health target, there is a health strategy, there is a health emergency, and therefore what I feel is a lot to be achieved through these webinars and also these programs. And I'm sure the eminent persons who are present here, like Dr. Gagandeep, I heard her in my last encounter with the Central University of Kerala on the Science Day, and I'm sure that the eminent speakers would throw light on the subject that is to be taken up by the institutions. So Dale College is there, Central University of Kerala is there, and so many institutions are there. Then what work they should be carrying out, and what could be the targets, and what could be the vision, and what could be the issues. I don't know how much of this could go into the curriculum part, infectious disease, and how do we really put this into curriculum and diagnostics, and maybe that is already there, but how do we really systematize? We are talking about NEP 2020. So in the NEP 2020, one of the most important aspects is multidisciplinarity and internship embedded program. So multidisciplinarity, how does it help science? How does it help medical science? How does it help health? So these are the very important questions that are to be probed. I request and I suggest all the eminent speakers to get into the status of the existing scenario and then come out with certain plausible solutions. And I'm sure the Kerala Academy of Sciences, which has a scientific pool in its organization and its committee, and it will work on the lines that the science has been propagating. My congratulations to all those who are associated with the program, and also my thanks to all of you for associating me with this wonderful morning. Though I wish I would have attended the program in physical. Yesterday only, I think I was in Trivandrum attending some program. So so many things that I have to catch up. Therefore, I could not be present. Otherwise, I would have definitely. GM Nair's word is almost a friendly law, I would say. If not constitutional law, it's a friendly law to me. I would really love to go with them. I visited their central instrumentation facility on my soon after my appointment as vice chancellor, and I was impressed. In fact, we started baby steps to develop that kind of a facility. And towards the end, what I can what I can say is an institution like Central University can take the lead with the Kerala Academy of Sciences in the propagation of science among school students in the state of Kerala. We have some physical infrastructure thanks to the central government. We have a policy, and then we would like to go for community development. Community development, I believe, not just giving vaccines, but community development could be giving a thought to develop science, giving some kind of science temper across the common citizenry. That is the most biggest ideal, noblest goal that an institution like Kerala Academy of Sciences and the Central University of Kerala can venture into and can take along with our medical university vice chancellor. Also, I met him recently, Professor Mohanan, and many other guys are there in the state of Kerala. All of us can come together and do a little bit to propagate the science and the science thinking and science advancement for the well-being of the people. I'm sure this international webinar will throw a lot of possibilities, lot of opportunities, lot of insights into the subject that has been chosen on diseases, on diagnostics, vaccines, and future medicine, and it will be of crucial help to the researchers, students, and the faculty. I wish the international webinar a grand success, and once again, I congratulate the organizers and thank the organizers for giving me this great opportunity to be with the scientific community of the state of Kerala, of India, and scientific community of the world. Thank you very much. God bless you. Thank you.
Inspiring words. As Aaron Rose once said, the right light at the right time, everything is extraordinary. So we move on to the inauguration function. For this, I invite the chief guest of today's function, Padma Shri M.C. Dattan, along with dignitaries to light the Nilavilakku and inaugurate the function. Thank you all.
Thank you, sir. Now, I request Padma Shri M.C. Dattan, Scientific Mentor to the Chief Minister of Kerala, to deliver the inaugural address.
Sri M.C. Dattan is an Indian space scientist and former director of the Vikram Sarabhai Space Center. He has graduated in chemical engineering from the Government Engineering College, Thrissur in 1971 and secured MTech from the Birla Institute of Technology. Sri Chandradattan started his career in 1972 by joining the Indian Space Research Organization, where he worked for the SLV-3 project, the development of solid propellant formulations.
He has published many articles in such journals of repute as the International Astronautical Federation. Sri Chandradattan is the recipient of many honors and awards, including Performance Excellence Award 2009 from ISRO, Outstanding Chemical Engineer Award 2009 from Institution of Engineer India, and Individual Service Award 2006 from ISRO. The Government of India honored him in 2014 by awarding the Padma Shri, the fourth highest civilian award, for his contributions to the field of science and technology. In 2015, the Government of Kerala appointed Dattan as the scientific advisor to the Chief Minister. Welcome, sir, for the inaugural address.
Very good morning to you all. Honorable Vice Chancellor, Professor Gagandeep Madam, distinguished scientists on the dais, and very beloved participants and students. In fact, when I have been invited to inaugurate this function, I was totally in a dilemma because the theme of the webinar, international webinar, I am not at all connected with any of that subjects. And I was under long apprehension on what to talk. But my close friend GM Nair, President of the Kerala Science Academy, told for all subject experts there are plenty of excellent talks are going to come. Sir has to come for the inauguration. And Alfie also has given me enough courage, sir, you come. Really speaking, after listening to the presidential address, I was totally happy. Because Vice Chancellor himself was told, he didn't have even that much connection with the science as I have. So I was extremely happy. I will, but these words touch me, 2, 3 words. Human development, what we are doing on the human development in the global standard. What kind of scientific temper we are able to develop with our people. After 75 years of independence, the first Prime Minister declared, the first year itself told, the poverty and the hunger from our country can be eradicated only by scientific achievements. And in spite of that, where is our standard now? Since the presidency has touched on the human development and the global standard, let me ask a simple question to you. What for we live? What is the ultimate goal or ultimate desire or ambition? Simple. We want to be happy. That's all. We want to be happy. Then the question comes, what is happiness? People say happiness is a state of mind and everything. But once you ask a question, what is mind? Answer is very, very difficult. When we talk about science, science tells about all physical things. Evidences and measurement is the basis for science. In our Malayalam, we call alavugalum telivugalumana science in the Shastrathinte Aadharam. Evidence and measurement. So what happens is science is unable to give a full answer for spiritual things, especially the belief, the emotional part of the mind, the defining mind itself, the feelings, the thought process, like that many. Let it be there. Why I introduced the subject is there is a connection between our theme of the webinar. That's why I'm coming. There is a book by Kochose Chitrapalli, the V-God man, the great businessman. Long back, he has written 2 books called The Practical Wisdom. Very small book, very interesting. It is somewhere in 2002, 2005 period, Practical Wisdom. I don't know whether now it is available in the shops. He has grown much, much higher after that. From his personal experiences, how he has grown. He was a scientist. He's a physics, MSc physics, started with electronics, ended up starting first with making a stabilizer. What he told there, what attracted me is he asked me a question: who is the happiest person? How you define a happy person? His simple way he defined. You ask 2 questions to you. And if you ask the answer yes, then you are the happiest person. First question is, are you feeling hungry at the appropriate time? I asked this question to students many times, but I told them, we are feeling hungry much ahead after that. That is the problem. Great. See, after eating something after 3 hours or 4 hours, if you are feeling hungry, you are one of the happiest person in the world. Why I am telling is, after some time, when you get aged and become old, you won't feel hungry. You have everything in front of you, all luxuries, but you are not able to eat anything. Then what is the need of life? So first question you got answer yes, so you are the happiest person. Second question is very interesting. He is telling, after a day's total work in the night, you go for sleep. You just went for sleep, for preparing for the sleep. Within few minutes, you are able to sleep comfortably in the night. This question I asked the children, told me we are feeling now itself sleepy. What a great thing. So if you are getting the answer for that also is yes, don't worry then. You are the luckiest and the happiest person in the world. That is the story part of it. Book. When you get time, if you are able to locate that book, you will love it. Very interesting. I read the book about something like 15 years back. Now I come to the subject, the happiness has got a connection with what President's letters Sir has told is the health aspect of it. In Ayurveda, in our ancient Grantham, Ayurveda, Arogyam is, what is Arogyam? Roga Vidyartha Avastha. There it is written, Arogyam is Sukha. Arogyam is happiness. And Rogam is Dukha. Rogam is disease. Now you look at that, one of the theme is infectious disease. Now you look at the word disease, how the word has come. Dis ease. Ease means, easiness means swasthata. Lack of easiness is disease. Aswasthata is disease. Dukha. So now you understand what is happiness, what is arogyam. Arogyam is the happiness and disease is the unhappiness. Now we are going to attack on the disease. Main important, as far as I am concerned, in the theme of the seminar, there are only 2 important words. One is the disease, how to attack the disease. Whether it is infectious disease, virus disease, whatever it is. The most important thing which you people, as I am only giving you an introduction to listen to the excellent lectures what are going to come in the coming hours. The most interesting subject is the molecular diagnostics. I will link my talk of the happiness to that. Molecular diagnostic is the most important theme of today's discussion. See, when the disease is to be resolved, treated, to be cured, first of all, we should understand the reason, root cause of the disease. That is diagnostics. In the early days, long back, only symptoms, doctor or physician has to treat and symptoms. My father was an Ayurvedic physician. I'm telling the story of 60 years back when I am at the age of 10 years. He was working as a physician in a pharmacy in Tamil Nadu. It's a very rural village where people are not educated. And after that, my father was telling the toughest portion of my life is there because the patients come, they will not tell anything about the disease. Because the physician should understand by looking at the body of the patient, he should understand what is the disease. By seeing, no, they will not talk what is the problem. Because otherwise, they know who is the physician. Physician should be capable of, maybe he can catch see the pulse and ask to open the mouth, open the eye, all these things work. That was once upon a time. Then later, the clinical chemistry came. We started taking fluids from the body, chemically analyze it, and then more data. When science has developed again and again, electronics and engineering subjects has gone to higher level, we started getting very sophisticated instruments like X-ray first. Then, again scanning systems, MRI, many investigative system has come. MRI, over the MRI, now there is a functional MRI, which I will explain last. All these are the things, but all these things has got limitations. Why limitations? The body is made by the creator, each body is made differently. Some medicines get clicked in a body. The same medicine for the same disease in another body, it will not work. Have you asked why? Have you asked? It doesn't work. So the way by which medicines work on a body depends on a lot of unknown secrets to the science. That is what we are going to slowly investigate and get the clue through molecular diagnostics. What happens inside? During diseases due to bacteria or virus or something, how the body systems change, how the microbiomes changes. In our body cell, how the DNA changes, how it is getting affected by the infection. Then only we will be able to select the correct medicine which will be able to cure the disease. So person to person it varies because of the cell or neurons, what you call it, etc. In the microscopic level we should go. That is what one of the major subjects, useful, very interesting subjects, the seminar people have mentioned, the molecular diagnostics. Why I put this and I am going to conclude, why I put this? Science, when you are talking about the physical thing, not on the spiritual things like emotions or faith or feelings. When you are happy, there are hormones or secretions or enzymes are all produced in your body through the systems. That is all, happiness hormones. There are about 4 or 5 happiness hormones available, Due to every type of happiness, you get a different hormones, which the molecular diagnostic system will be able to find it out. Then you can artificially also create happiness. by injecting such things hormones into your body in a proper way to the cells. Very fantastic things. Then nowadays doctors, after treatment and everything, giving medicine, etc., the very desperate patient will ask him, sir, doctor, will I be all right? Then doctor will just smile, tell, take all the medicines as I advise, and then pray. Why? Then pray. Why? That means first you have to believe your doctor and believe your medicine. That's a mental status. Like I told, the happiness is a state of mind. In the mind, there are so many processes happens. And accordingly, the fluids or secretions or enzymes or hormones, whatever you people, scientists people call it, they are produced and go to the cells of the body in a different way and system changes. Once we know the molecular diagnostic systems, slowly that part of the science is only 40 years old. I think in 1980 or something, only the molecular diagnostic system has come to a shape. The latest field, we have to understand those things and understand how in a cell structure wise these things affect, so that we can find out the real cause of a disease. And person to person, different treatment is required. Different medicines are required for person to person, depend on his body conditions, cells, genes, genomes, and etc. In that way, science is advancing one more step. And then after some time with that, science is not physical alone. Science can answer spiritual things also, about the emotions, about the feelings, about happiness and about worries. What happens in your body, science is able to go into answer. And after that is I told. In fact, if even our thought process, the neurons responsible for each kind of thoughts, neurologists were not able to tell. They can only tell in location, in a particular location. But now there's a functional MRI they take it. When your brain is in movement with respect to different emotional way, etc., the MRI is being taken and they study and analyze slowly. That science also is advanced. So a lot of things happen. You are going to get wonderful lectures in the coming hours, etc. Please be listen. And the points what I told, keep it in your mind. Try to relate to the day-to-day life also on the miraculous creation of the creator, the human engine. We engineers call it is a miraculous engine. The human being could not develop any engine which will come anywhere near to this body engine. Body engine is fantastic, very miraculous. So appreciate that. Completely listen to things, make it useful to your studies, and do it with these few words. I thank the organizers for giving me a chance to be here, a part of this great event, and formally declare the webinar, international webinar, is inaugurated. Thank you, sir.
Thank you so much for such an enthusiastic novel address. Now, to deliver the keynote address, we welcome Professor Dr. Gagandeep Khan, FRS. Gagandeep Khan is an Indian microbiologist and virologist, professor in the Department of Gastrointestinal Sciences at the Christian Medical College, Vellore, and was the Executive Director of the Translational Health Science and Technology Institute, Faridabad. Khan completed her medicine degree and Doctor of Medicine in Microbiology from Christian Medical College, Vellore, and obtained PhD in 1998. She has published over 300 scientific papers. She is on many review committees
for National and International Research Funding Agency and has served as on several advisory committees, mainly related to vaccines, including India's National Technical Advisory Group on Immunization, the World Health Organization's Global Advisory Committee on Vaccine, Safety and Immunization, and Vaccine Implementation Research Advisory Committee. She chairs the WHO Regional Immunization Technical Advisory Group. Since 2020, SARC has been an ex officio member of a working group on COVID-19 vaccines established by the Strategic Advisory Group of Experts at the WHO.
Cam is the first Indian women scientist to be elected a Fellow of the Royal Society in 369 years of history of the Scientific Academy. She was the ninth woman to be awarded the Infectious Prize. She is the first Indian woman and the first woman to edit Manson's textbook of tropical medicine. She was awarded the prestigious Infectious Prize in Life Sciences in 2019 for her contributions to understanding the natural history of rotavirus and other infectious diseases. Cam is the co-author of book Till We Win, India's First Fight Against COVID-19 Pandemic, with Chandrakant Leharia, the director of AIMS New Delhi. The book has been published by India's leading publisher, Penguin Random House India, and has become an instant bestseller. We proudly welcome you, ma'am, for the keynote address. Welcome, ma'am.
Thank you very much for inviting me here, particularly Dr. Nair. I'd like to be able to share slides, but it says that the host has disabled participant screen sharing. If it's possible to enable that, that would be very helpful. Can we get the organizers to enable screen sharing?
Yes, ma'am, you can. Yes, ma'am, you're able to screen share.
Okay, that's great. So I'm going to be talking to you today about building towards pandemic preparedness. And I hope that over the next 25 minutes or so, I'll be able to take you through an overview of how we can think about this. So if we think about public health emergencies, they can come in many forms. There are chemical emergencies, all kinds of leaks, oil spills, etc. Radiation emergencies that we've seen in Fukushima and Chernobyl. There can be mass casualties because of a number of reasons, mostly related to natural disasters and to situations of conflict. We can have the threat of bioterrorism, which, the sarin attacks in Japan were a recent example of that, as well as the mailing of anthrax spores shortly after 2001's 9/11. But the emergencies that we are seeing more frequently now are severe weather emergencies, flooding, cyclones, etc., and pandemics. In the 21st century alone, we have had many major outbreaks of infectious diseases, whether that is SARS or MERS or Zika or influenza, and most recently SARS-CoV-2. Now, if we look at infectious diseases that cause outbreaks, we can have communicable diseases. Most infectious diseases are communicable because in one way or the other, they spread from person to person. And the routes of infection can be through food and water, can be through direct contact. An example of that is Ebola. Or they can be, as we have seen most recently, the respiratory route, which can result in the most rapid spread. Infections can also be endemic, which are established in populations, epidemics, which are outbreaks that are limited to geographic locations and pandemics that cross several geographies. So diseases that spread across multiple continents become pandemics. And if we think about pandemics, I think the value of emergency planning and response are clearly evident. Because if you have planned for a situation, you become able to handle it more easily and limit the amount of damage. So harm reduction and the promotion of benefits are obviously a key reason why we have emergency planning and response. But it actually goes a lot further than that. It results in greater equity, that people's rights are protected and the benefits are distributed across the population. As we have seen in SARS-CoV-2, sometimes we have had restrictions on civil liberties that were inappropriately designed and implemented. They did result in some benefit in terms of controlling the spread of infection, but they also resulted in a fair amount of harm, both in terms of economics and the emotional damage that was done to people. So thinking about liberty, human rights, and distributive justice also allow us to limit responses to what carries the greatest benefits and the least risks to our population. And then, of course, in an emergency, accountability becomes very important. When we have resources, and those resources must be spread across a range of needs, it is a responsibility of structures to make sure that those resources are most appropriately used. So public accountability and the ability to communicate transparently how those resources have been used becomes facilitated by having a planning system that is already in place. Then if you have communities, thinking about community participation is absolutely essential, particularly in the case of pandemics. And being able to have strong and resilient communities that have been communicated with ahead of time can result in the success of the endeavors that have been designed to control the pandemic. For public health, of course, it is absolutely critical that there is preparedness, because that is essential to be able to protect the public, which is the responsibility of this profession. And then civic and personal responsibility also become facilitated if there are actually plans in place. Now, if we think about the stages of a pandemic and where we need to think about what needs to be by whom, essentially, you can divide it into 5 phases: detection, assessment, treatment, escalation, and recovery. Detection is when a pandemic has been declared by WHO or earlier. Assessment is when the first patient with the pandemic flu strain is identified, to think about what this will actually escalate to and what will be potentially required. And then thinking about what kinds of treatments are required, both in terms of treating cases, but also preparing for increasing numbers, even as we think about the measures that are required to slow the spread. And then escalation, when the pressures on services and wider society begin to become extreme, where we have to think about adjustments to service delivery systems, because the demands are so much that it's not possible to serve everybody at the level that might be required. And finally, once all these measures are implemented, to think about recovery. When the peak has been passed, how do we think restoring services back to normal, and thinking about preparedness for future resurgences of this same pandemic or future waves that might be seen. I just want to highlight, because you're going to be talking about diagnostics at this meeting, as well as therapeutics and interventions, I'd just like to highlight some aspects of early stages of detection and assessment, where we have recognized in this pandemic that it is essential not only to think about patients, but also to think about how we can assess risk looking at novel technologies. One example of that is what has been highlighted in this pandemic, which is wastewater-based treatment, where it has become possible through the sampling of sewage systems to be able to predict where disease may arise next. So as an example, right now in the US, there are 23 locations that are showing an increase in SARS-CoV-2 detection in wastewater, where cases have not yet been identified. And this is a potential significant concern as we anticipate the next wave coming. It's also very important that we continue to monitor the pattern of disease that we are seeing in different locations to understand what our own situation might look like in the future. Particularly in the early stages of the pandemic, it becomes absolutely critical to look at patterns in where the disease has emerged first to predict what might happen when the disease comes to our own locations. And the important thing to remember is that it's important not just to track cases, but also to look at other parameters of data that are critically important. Hospitalization is obviously important, but in India, by and large, we have tended to look only at cases and deaths in terms of total numbers, as well as a population level estimate per million population. Now, as the pandemic evolves, some of these measures, particularly cases, become less important. When you have a high number of cases but more low, as has been seen in the Omicron wave, it becomes then essential to also be able to track hospitalizations to assess the severity of disease and therefore what resource requirements are likely to be needed. Now, if we think about therapeutics, one thing that I would like to point out that preparing not only to discover and use new therapies is important, it's also important to evaluate their applicability for a particular situation. So for example, within the first 6 weeks of the SARS-CoV-2 pandemic being established in China, 120 clinical trials were registered. None of those trials actually reached their sample sizes or resulted in information that could be used. The UK went with a different approach where they got the entire health system to participate in a trial called Recovery, randomized evaluation of COVID-19 therapies. And the Recovery trial has been the most useful trial for global endeavors. The Solidarity trial conducted by WHO on similar lines was also very important. The first methazone being useful came out of the Recovery trial. So being prepared for large-scale trials, for therapeutics, for new pathogens is absolutely essential. Why was Recovery able to do it? Because they have a health system that is actually linked, and it was possible to leverage that to be able to do the therapeutic studies. Similarly, in the US, why were they able to get results for the Pfizer and Moderna studies within 3 months of starting their phase 3 study, whereas in India, each of our phase 3 studies took actually about 6 months or more because they used networks of trial sites that had been established well before the vaccines became available. So preparedness for research is also a key part when we are thinking about dealing with a new pandemic. Now, coming to escalation of the pandemic, when resource requirements are high, how do you do triaging? How do you do allocation of resources? We saw this where there were significant differences. Health systems were managed in northern India and in southern India. In northern India, what we saw was largely a collapse of the health system in April of 2021. Whereas in southern India, through the mitigation measures and the preparedness that had been put in place, we did not have to face the kind of devastation that had been seen in the north. Imagine if what had been done in Tamil Nadu or Kerala had actually been in place in Delhi and other parts of northern India where the health systems were overwhelmed. Coming finally to recovery and preparedness, that's where we are now. And I think the two words that need to describe recovery and preparedness is hope that things have settled down, and caution, because we know that things can get worse again in the future. So thinking about the stage at which we are and what needs to be done next is absolutely essential. And whatever preparedness we do, it needs to be multifaceted and needs to have evidence-based strategies. The UK, for example, uses an approach that is called defense. This is a strategy that's useful for us to consider because it takes into account surveillance and modeling that detects and assesses the impact of any new virus, identifies and quantifies risk, looks at who is most at risk of severe illness, hospitalization, and death. This requires both the ability to do surveillance and do modeling, but also the tools, the diagnostics that are required to be able to implement that. Second is looking at the public health functions, reducing the risk of transmission. How do we ensure that we have good infection prevention and control practices, not only in healthcare settings, but also in communities? It's most important to start this in healthcare, particularly through the use of personal protective equipment, which should be held in stockpiles, but also to think about the right policies being in place and the right communication strategies for communities to be able to also participate in the behavior change that is required to reduce the risk of transmission. And then we come to minimizing serious illness and deaths. We know that certain kinds of drugs are useful, antivirals, antibiotics, steroids, etc. Those therapeutics need to be held in reserve. And if they aren't, then we should be thinking about evaluation of new therapeutics. There are also other approaches that need to be taken to reduce the pressure on primary care services and hospitals by activating strategies that keep less well individuals out of hospital. This can be through teleconsultations, through giving of prescriptions for drugs for patients, for thinking about self-monitoring approaches, care at home, etc. And then for governance structures, we need to have arrangements like advance purchase agreements so that there aren't shortages of supply. We need to think of prevention strategies where those are possible through the availability of vaccines. And of course, we need to think about a rapid research response for both implementation and tools so that whatever strategies are followed are actually based on evidence. Now, emergency preparedness and response has holders, public health departments, local hospitals, practitioners, care centers, police departments, other authorities, religious community organizations, schools, etc. And we also need to think about the implications of pandemics, because interventions here can affect personal freedoms, especially when you're isolating infected or ill citizens, or quarantine, or closing schools, canceling events, restricting access, changing work practices, changing travel. All of these and their implications need to be thought about. Resource distribution in a pandemic obviously becomes complicated because goods become scarce or unobtainable. There are many parties that are involved in allocation, and not everybody will necessarily get the care that they believe they need. One example of where things got complicated in this pandemic was where people were put into hospital that didn't really require hospitalization, and that resulted in care not being available for severely ill individuals. So we need not only facility-based plans, but community plans. We also have to think about people who have special needs. Some people are more likely to contract a disease than others. Tribal populations, the disabled, children, the elderly, the poor, and we need to make sure that they are considered and given appropriate information when planning for pandemics. Civic rights are important. We saw what happened with migrants. And I think thinking about situations where populations or subpopulations may be severely affected is important. And providing people with truthful and complete information regarding the emergency response, instead of treating it as a law and order problem, becomes critically important. Responsibilities, we need to think about individuals. This is an example that comes from the CDC in the US, where they have suggested to individuals that if there is a public health emergency, that individuals and families, how they will respond to a pandemic situation or to a public health emergency. What constitutes an emergency supply kit? How will families communicate with each other? What really is required for logistics and support? The other thing to think about is actually doing scenario planning. And there are a number of exercises that I'm not going to go through here, but which are tabletop planning exercises that are essential for preparedness goals, where you can model what might happen in a pandemic. Not everybody, no organization, no geography is always fully prepared, but this kind of planning where you structure the different phases of a pandemic and early stage, what could potentially happen when rumors start to spread, when there is a situation where an increasing number of people are encountering a disease. What do you think about? What are the mechanisms that need to be put in place? Who the stakeholders are becomes critical. And this can be modeled as a progression exercise where you have an early phase, you have an intensification phase, and different kinds of questions are addressed in different phases. So you go from intensification to a widespread pandemic, and you think about what needs to be done at each of those stages and what are the potential kinds of scenarios that might be encountered. So each of these, the situation, the questions, the considerations can really help in planning for pandemic preparedness. So just to end, if we are to develop pandemic preparedness, there are three key pillars. One, of course, is governance, to have the right structures in place. The second is trust and communication. And the third is to have competent people to make sure that whatever contingencies are required, we are actually enabled to be able to address all of them. So I'll thank you very much for your attention. And thanks once again for inviting me to join you here.
Thank you, Professor Vegandeep Khan. This is Dear Man. I'm extremely sorry for the delay. You have accommodated yourself within the time frame. Thank you very much for accepting my invitation on a very, very short notice. And speaking on a different aspect, I heard you some few days back while you were speaking in Central University of Kerala, but you have just approached a different aspect here. And I'm so happy that you could make this lecture within this short period of time. I know your services, your help, when Professor Rattan was telling about the way you have advised students, when there were all problems regarding the death rate, you only said to them, to the government, to the Chief Minister, that your death rate, the death rate in Kerala is very low. And that means that there was a reassurance, the approach that the government of Kerala is doing in controlling this disease. Your talk, especially on the recovery and preparedness, because preparedness I do not know. People are talking about a fourth wave to come. I do not know whether the fourth wave is again going to come, or maybe that we are all specifically immunized that will not be the impact. And as my invitation goes with you, that we should visit the Institute of Advanced Virology. I will call you specifically for a program over there, because you know that this is most prestigious institution we have built in Kerala, addressing all those problems that you have said, and your help, your guidance, your tracking is very important for making this institute go forward. So we look forward for all your association with this institute, with the government of Kerala, with all of us, because we are worried whether we will be affected by the fourth wave. Thank you, Professor Khan. It's so kind of you that you've accepted with a short invitation, short time, and you have very specifically accommodated your talk in 20 to 30 minutes. As though I had told you that you can take about 45 minutes. Had you taken 45 minutes, that would have been no problem at all, because I'm sure my students have been very keen to listen to you. Maybe that since it's a keynote address and we are principally delayed, that we will not further make them ask questions, but I'm sure that I will pass on your email, and if they have any doubt, they will clarify. Thank you very much, Professor Khan. Wish you all the very best. And
thank you very much.
Being the first woman scientist for having received a FRS, please go and receiving great accolades to the country, and so that we'll be able to face the world with a lot of confidence and courage. Thank you very much. Thank you very much.
Thank you, sir. Now, I would like to invite Mrs. Deena Das Ma'am, Chairman, the Navy College of Pharmacy and Research Center, for delivering the vote of thanks. Thank you.
Dignitaries on the stage, off the stage, and those who are joined online, and dear faculty members and my dear students. It's a great honor to propose the vote of thanks to all who have helped us in making this hybrid seminar a very resounding success. It is the biggest day in the history of our institution. Today, we have hosted one of the biggest hybrid conferences in association with Kerala Academy of Sciences and Central University of Kerala, Kasaragod. More than 300 representatives from different colleges and universities are participating in the ceremony through online and offline mode, which is a huge success. Today, we were blessed by the esteemed presence of Padma Shri MC Rattan sir, who left us a little while ago. His presence and talk was very thought-provoking and interesting one. And I truly believe that it has enriched all of you. And on behalf of the organizing committee, I convey deep regards and hearty thanks to Gagan sir. Also, I would like to thank our distinguished speaker, Professor Dr. Gagan Khan, who delivered the keynote address. I'm sure her presentation has enlightened all of us on the different stages of pandemic preparation and the role each one of us has to play to manage the pandemics. And it was an excellent presentation, and it made this seminar a very meaningful and interesting one. On behalf of the organizing committee, I express my deep gratitude to Professor Dr. Gagan Khan for her presentation. Address by Professor Dr. H. Venkateshwarlu, the Vice Chancellor of Central University of Kerala, who presided the function. It was a great honor for us to associate with the university and as well as the esteemed Vice Chancellor. And I extend our heartfelt thanks to the Sir also. An event of this dimension cannot happen overnight. The wheel starts rolling months in advance. We have been fortunate enough to be backed by very motivated and dedicated scientists of Kerala Academy of Sciences, especially Dr. G.M. Nair, sir, President of the Academy. I cannot thank everyone enough for the involvement you have shown from the start and for the trust Sir had on us, and to partner with us and interest this big event for us for coordination and conduct. We are highly indebted to Dr. G.M. Nair, sir. Words are not enough to thank you for your constant guidance and support to shape this conference. Now, on behalf of all of us,
a very warm, hearty thanks to you, sir. Sir, I request that we have a small token of gratitude to you. I also thank Dr. K.P. Ramesh Kumar, the Secretary, Kerala Academy of Sciences, for his constant help and guidance that radiated a source of energy within us. We will remain grateful to you, and also we thank you for being with us today, sir. Ramesh sir, thank you. I'm also very thankful to Dr. Pandurangan sir, the former director of PBGRA, Dr. Mohanan sir, scientist of Sri Chitra Tirunal Institute of Medical Sciences and Technology, Dr. Annie Abraham, and other Dr. Reghu, and other distinguished scientists who are assembled here. And I also thank all the invited speakers and the honorable delegates who are joining us online also. I would like to give my vote of thanking to the coordinators of this entire event, especially Dr. Shaiji David Alfie, our CEO, Dr. Manoj Kumar, Principal, the 8th Sem B.Pharm students of the Delhi College for making all the flyers, videos, anchoring, and a full-fledged coordination with the faculty members for making this event a great success. The support by Sri Sajeev Nair and the IT team Benny and Shibu has to be specially mentioned for their technical expert and support. I'm also very much thankful to all our current faculty colleagues and non-teaching staff members who always stand for us and motivate us. I feel proud and thank you for making this event a successful one. Thank you and have a fruitful day ahead. Thank you so much.
Thank you, ma'am. Dear delegates, once again, I welcome all of you to the much awaited invited lectures of the International Hybrid Seminar. We have an array of stalwarts in different fields of science today with us. Let's start with Dr. Shyam Sharma. Let me invite Dr. P.V. Mohanan, scientist, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Thiruvananthapuram, to introduce Dr. Shyam Sharma.
Yeah, good morning to all. And I would like to introduce Dr. Shyam Sharma, who is a
Hi, I'm.
Hi, sorry.
Yeah.
It's a good friend of me.
I'm there. Okay.
I saw you, Dr. Sharma. And Dr. Sharma is a professor of pharmacology at the National Institute of Pharmaceutical Education and Research, that is NIPER, Mohali, Punjab. He has more than 20 years of research experience in the area of neuropharmacology. And before joining NIPER, he worked as a postdoctoral fellow at the UIC, Chicago, USA. And he did his PhD in pharmacology from AIMS, New Delhi, under Professor Y.K. Gupta. And he has more than 100 research publications, patents, and book chapters to his credit. He is a recipient of OPPI Scientist Award in 2012, ICMR Shakuntala Amir Chand Prize, and IPS CDRI Oration Award, and PP Surya Kumari Prize. He is a fellow of Indian Pharmacological Society and member of several scientific bodies. Apart from that, he is a good, a scientist, a teacher, and overall a good human being. So thank you, Dr. Sharma. So welcome to this gathering, and I'm.
Yeah. Good morning. Good morning. Actually, like Professor Nair and Professor Mohanan, I think it's a great opportunity for me to be here in the conference, and thanks for the invitation.
Okay, welcome.
Yeah, and one of the main thing actually I can say that I'm really privileged actually to give a talk in a college of pharmacy, because I belongs to actually this NIPER, National Institute of Pharmaceutical Education and Research, and giving a talk in one of the prestigious Daleview College of Pharmacy, that's my privilege actually. Thank you. Okay, let me share my screen. Just actually, I would like to know whether I'm audible.
Yes. Yes, it is audible.
Am I audible?
Audible. Dr. Sharma, you are audible. Dr. Sharma?
Yes.
Yeah, you're audible.
Okay, I'm audible. Fine. Okay. Yeah. So I think like this is very good conference. I think this Kerala Academy of Science is biotechnology, particularly like I know Professor Nair, he is one of the really very nice person. We have met him in SERB as a chairman of our committee. And that interaction is going on actually, and hope we have more fruitful interaction, I think. Today I'm planning to just give you some brief idea about like how the cardiovascular safety assessment of various pharmaceuticals can be done actually, and how this COVID-19 drugs actually they have been investigated for cardiovascular complications in various situations actually. So I think like all of you know about it that this coronavirus actually, because Dr. Kang already gave you a lot of ideas about like how this pandemic was there actually, and this virus is has created a lot of havoc actually in last 2 years, and is continue actually. Yesterday I just gave one talk in conference post-COVID. So I told them it's not a post-COVID. I think like the COVID is still going on, and there might be next wave in next 3-4 months if we are not taking the good control of wearing masks and other controls. So I think there's the figure. If you see the worldwide, like COVID-19 cases, about like 46.20 crores, and death about 60 lakhs actually, more than 60 lakhs. India even around 4.29 crore. This is a figure was yesterday actually, and the death 5.16 lakhs actually. And if you would have seen actually this particular article, which was published in this journal, like signal transduction target therapeutics. Actually, they have summarized like all kind of drugs actually which have been investigated for the treatment of COVID-19. So now you know that I think these are the two membrane protein like ACE2 and TMP-RSS, this kind of a like transmembrane protease, actually serine protease 2. And generally like this virus actually bind with these protein actually then getting the entry into the cells like endothelial, epithelial, respiratory, nasal, and all this has been shown. So now like you can see several drugs which have already been investigated and used, and inhibition of the entry of this virus, a lot of investigations done. And at that time, there's even the hydroxychloroquine actually that was the being initially given to the patients actually for inhibiting the entry of this virus. Protease inhibitors, which are already being used for the treatment of HIV, they were being used. Anti-RNA polymerase like remdesivir, ribavirin, and favipiravir actually they were used. Other antiviral, which is already used for H1N1 actually or H5N1, oseltamivir, that was being used. And in addition, actually, like, there was some immunomodulatory approach like corticosteroid therapy or covalescent plasma therapy. They were used because they were inhibiting the cytokine storm over there. So that those kind of like investigations have shown remarkable effectiveness in some of the clinical studies. If we look at like number of drugs actually which are there in being investigated in clinical studies, actually you can see the more than 50 of the antiviral in different phases of clinical trial. Cell and gene-based therapies, immunomodulators actually 120 plus actually, neutralizing antibodies, more than 60s actually, and other like targeting a different pathway, and even the combinations of like various agents also being investigated. So there's a lot of hope actually in future. Actually, we should not have like much problem, much complications with COVID. Okay, so this slide is particularly like indicating about. Let me just put a pointer. Okay, yeah. This slide is showing about the theme I was talking about, this cardiovascular complication which are associated with the drugs for the COVID-19. It's not only COVID-19 drugs, even the COVID-19 itself was causing cardiovascular complications. So that is why it's kind of a bi-directional interaction was there. It has been seen that this viral infections, this virus like SARS-CoV-2 actually was inducing myocarditis actually. It was inducing having the long-term effect like because of the systemic inflammation, cytokine storm was there. That was inducing a lot of effects on our body from like acute cardiac injury, myocarditis, acute coronary syndrome, arrhythmia, thromboembolism. And there were like potential drug initially, like they were tried like hydroxychloroquine, actually like different doses was tried, and that was causing. Even the azithromycin. The major issue was always there, like when you combine this hydroxychloroquine and azithromycin, they were causing more and more QT prolongation, and the ventricular arrhythmia was reported. And even the patient who had underlying comorbidities like hypertension, coronary artery disease, or ischemic heart disease, or diabetes, they were more prone to have like these kind of complications. Several drugs were developed, like, like initially, everyone know that most of us, we were on antihypertensive like ACE inhibitor, angiotensin converting enzyme inhibitors, then angiotensin receptor blocker, which act on angiotensin 1 receptor blocker, and thiazolidine. They also like looked into like whether they have any effect on the cardiovascular complications or not, or because one of the issue came related because this virus was binding with the ACE2, which is an angiotensin converting enzyme, which is involved in the synthesis of angiotensin. I'll just talk about. So these are like main pathways which were considered to be the cardiovascular complications can be associated with. It may be direct cardiotoxicity of any drug, actually that can also be there. Systemic inflammation, actually that was there in the COVID also, that was the, can be the mechanism of cardiac damage. Mismatch of the myocardial supply and the demand. Generally, like in normal physiology, we have a balance of like myocardial oxygen and supply as well as the demand. And if there is an imbalance between myocardial supply and this demand, there's the chances of that ischemic damage will occur. Myocardial ischemia or anginal pain is because of this imbalance between myocardial oxygen supply and the demand. And even like there were the reports which was shown that this COVID-19, these drugs also can rupture the plaque and the thrombosis of the coronary arteries, actually that was found. Disseminated intravascular coagulation due to sepsis, because like this COVID infection was considered to be the hypercoagulability stage. And that was observed actually like after COVID infection. Imbalance of the electrolytes. If there's imbalance in the sodium, potassium, calcium in our body, okay, that can also lead to cardiovascular complication, because they can interfere with the action potential actually of cardiac muscles actually. Endothelitis, like an endothelium damage, inflammation of the endothelium, that was another point which was came out actually when the scientists have looked into like how this can be investigated. So now I think like this slide indicate about like this angiotensin converting enzyme. This is one of the major target for the treatment of hypertension. We have in the market actually already a lot of angiotensin converting enzyme inhibitors like captopril, enalapril, ramipril. They are being used by the patients actually. In addition to that, like we have these blockers which can block this angiotensin receptor, actually, angiotensin 1 receptor, using like angiotensin receptor blockers like losartan, candesartan, irbesartan, all those pharmacological agents, they can inhibit this. So now you see, if you will see this particular pathway, and generally we call it like RAAS, like renin angiotensin aldosterone system. Okay. So this angiotensin, which is a vasoconstrictor, it is powerful vasoconstrictor in our body actually. Like, okay, in our body we have adrenaline also, that's a vasoconstrictor. We have endothelin, that is also a vasoconstrictor. But this angiotensin basically like converted by this ACE to angiotensin 2, and this is having the vasoconstrictor effect actually. Okay, and there are like before this actually pathway is that this renin is the enzyme actually which basically convert angiotensinogen to angiotensin 1, and then this ACE convert this to angiotensin 2, having the powerful vasoconstrictor effect. So now like this angiotensin 2 is basically like converted to the protective angiotensin 127 by ACE2. And it was seen that actually like this virus is recognizing this ACE2. And if it is like if any person is having ACE2 overexpression in their body, their like chances of like infections are high actually, and more damage was seen in those cases. So that was like point came like down regulation of the ACE2 by SARS-CoV infection was looked at into like leading to the cardiovascular disease and the lung injury. And these blockers like ACE inhibitor and angiotensin 2, like they were thought like because administration of these can also lead to, because they are being used for the treatment of hypertension. Initially there was a concern like whether we should stop like giving hypertensive agents, antihypertensive agents or not. No, but there are a lot of studies shown that, okay, no, there's not much association, actually not much actually alteration in the cardiovascular effects actually with this one. And they were not altering much with the ACE2 expression that was also seen. And that case actually when in March, you know, that pandemic was started, I think the pandemic started in 2019, some cases, but in India, like you would have seen in 2020, Nature Medicine, they published this paper, actually, like the QT interval in patient with the COVID-19 treated with hydroxychloroquine, azithromycin. And American College of Cardiology also came up with a paper like ventricular arrhythmia, risk due to hydroxychloroquine, azithromycin treatment for COVID-19. The point was that actually like these drugs actually like generally in normal cases that the heart contract actually and then relax actually. So this what happened actually in the after administration of this hydroxychloroquine and hydroxychloroquine plus azithromycin, what will happen like this relaxation taking more time and leading to the QT prolongation and ventricular arrhythmia, and the chances of the death was high actually whenever this QT prolongation is there. The drugs which are being used for treatment of COVID-19, like chloroquine, hydroxychloroquine, they showed direct cardiomyopathy. They showed conduction AV block, ventricular tachycardia or ventricular fibrillation. Heart rate goes very high actually. Okay, maybe like more than 200 or so. Tocilizumab actually, which is a monoclonal antibody for cytokine storm, inducing hypertension and hyperlipidemia. Ivermectin and niclosamide was inducing tachycardia, orthostatic hypotension, and PR interval prolongation. And fingolimod was like inducing bradycardia and atrioventricular block and hypertension. So that way, like several of these kind of effects are being produced by these agents. And that is why like this cardiovascular safety is one of the major concerns for every cardiologist actually, because or maybe the physicians, those who are treating these patients. So yesterday we had a very good interaction with one of the cardiologists and all, and they showed like they told like how they dealt with this particular problem. But I can tell you, like because I'm giving this talk in pharmacy college, and they have a opportunity like they can look into working in this area of cardiovascular safety. They can develop this kind of a program, and many of their master's students or doctorate students can work for these kind of programs. I think. So now, like the point I would like to make that one. If you see this particular slide, actually, like you can see over here that ECG wave, like this is P wave, this is Q, okay, R wave, and this is S wave, and this is T wave. So now this actually like QT interval, actually like this Q wave is starting of this to T wave, this interval. If there is a like increase in the QT interval, okay, that can lead to the ventricular arrhythmia, and the chances of the death would be there. And many of the drugs actually, they have caused this torsade de pointes phenomena, QT prolongation, and leading to withdrawal from the market. These were the blockbuster drugs. They were withdrawal from the market, like prenylamine, lidoflagin, terodilin, sertindol, which is antipsychotics, terfenadine, you know, it is one of the anti-allergic drug. Okay, blockbuster drug, it was withdrawn for the market. But later on, actually, the scientists, this is the advantage, like drug discovery scientists, they looked actually, okay, maybe it is causing QT prolongation, it was withdrawn, but it's metabolite, okay, fexofenadine, which do not cause QT prolongation. Now, fexofenadine is there in the market. Estimazole, which is another anti-allergic drug. I think most of you, like whenever you get allergy, you would be taking this cetirizine. Cetirizine, another anti-allergic drug. Okay, that cause little sedation, but no QT prolongation, and that is why like levocetirizine and all, those are being taken by during the allergy cases. Grapefloxacin, antibiotics actually. Cisapride, which is a prokinetic agent acting on the serotonergic 5-HT4 receptors. It is the agonist for serotonergic receptor 5-HT4 receptors, and that shows that was also withdrawn because it induced like kind of prokinesis, like from the esophagus to the colon. That was one of the advantages. Okay, droperidol and levoestylmethadol. Several drugs have been withdrawn from the market because of this QT prolongation, because that can cause actually like cardiac issues. Actually. So now I think like this ICH. This is like one of the organization. Initially, it was a international conference on harmonization, but now it has been considered as a international. Now, like it has been renamed as the International Council for Harmonization. Actually. So this, if you can go to this particular website, www.ich.org, and you can find the detail about that. Like this particular organization is basically harmonizing the various guidelines. And the advantage of this harmonization is that, like, if Japan is approving one drug, actually, it will automatically will be considered by European Union, all the countries actually, and as well as that by the US actually, because those are the major players in the pharmaceutical market. Okay, and they came up actually, why don't we harmonize these guidelines and look into very like quick availability of those pharmaceuticals which are of importance to those countries actually. So there are several regulatory guidelines which have been looked into by this ICH, like ICH I7A. S7A means safety, assistant to safety. Okay. Guidance ICH S7A, safety pharmacological studies for human pharmaceuticals, and guidance ICH S7B. So these are the guidelines were developed like when they've seen that terfenadine was withdrawn. Most of the companies, they are spending $1 billion, more than like 7,000 crore rupees for developing a one drug. And whenever it's reached to the phase 3 trial or maybe in post-marketing surveillance, that has been withdrawn from the market. So that's a big loss for the companies. And that is why they have gone into this kind of a guidelines actually, so that QT prolongation can be investigated before administration to the human actually in the phase 1 clinical trial. So before conducting phase 1 clinical trial, actually these studies need to be done, and then actually once actually clinical trial is going on, then also you also need to do ICH E14 guideline. You need to follow, because this is on the clinical evaluation of QT. QTC means corrected, QTC interval prolongation, and pro-arrhythmic potential of non-anti-arrhythmic drugs. So these two guidelines, S7A basically for new chemical entities, S7A and S7B, and this is during the clinical trial. So these need to be done in a GLP conditions actually, and that is required actually for filing of IND, investigational new drug application. And most of you from pharmaceutical background, the students who are attending physically, okay, and that's you can go through these kind of information. So what are like kind of objectives like S7A guidelines would have? So this safety pharmacology investigate the potential undesirable pharmacodynamic effect of a drug substance on physiological functions in relationship to exposure in the therapeutic range and above. So if like you will come to know like what are the different side effects actually, or whether they are causing any QT prolongations or any those kind of studies that we can look into. To identify undesirable pharmacodynamic properties of any drug, so you have to administer the drug in animals actually, and you have to observe whether it has like it is safe for the CNS, safe for the cardiovascular system, or it is safe for the respiratory system. These guidelines also evaluate adverse pharmacodynamic effect, investigate the mechanism of action of the, what is the mechanism, how it is inducing, why it is inducing, and to protect, major goal is to protect clinical trial participants from potential adverse effects of pharmaceuticals. So this is one of the major I think, point which need to be considered, that how it can, so that it should not cause any damage to the participants. And scope of these guidelines, these applies to new chemical entities and biotechnology-derived products for human use. These guidelines may be applied to marketed pharmaceuticals when appropriate. Okay. Even like during clinical trial, like if there is a cause of concern and some cardiovascular side effects are reported, then again you have to come back and you can do in animal. Why? What is the mechanism? Because some of the studies which you cannot do in human, you have to come back to the animal sector. Even for biotechnology derived product, we have the guidelines like S6A, safety S6A guidelines for biotechnology derived product. So if you know the kind of a drug discovery cycle, because you are in pharmacy school, initially whenever any lead molecule is identified, actually, all the molecule need to be tested for HERG, HERG testing. So these HERG assay, human ether agogo related gene. So this is the gene actually which is responsible for the expression of potassium channel. If any drug is blocking potassium channel, they are prone to cause QT prolongation. During the lead optimization stage, action potential studies can be done, patch clamp studies can be done, and even in addition to small animal cardiovascular studies need to be done. You need to measure the blood pressure, heart rate, cardiac output, all can be done, and in-depth cardiovascular profiling in non-rodent. And for preclinical development, if you are going for regulatory studies, actually for regulatory submission of investigational new drug application, or whether it's a COVID-19 molecule or any other molecule, any molecule, you need to do these studies, safety pharmacology studies, in a GLP certified laboratory. And Professor Mohanan is one of the renowned experts in the area of GLP, because he has served this as GMA for more than 20 years as a GLP inspector, lead inspector. So I think like all of you must learn GLP from Professor Mohanan whenever you get opportunity. And the timing of safety pharmacological studies can be done like prior to the administration in the human. As I mentioned, like phase 1 clinical trial, you are going to administer the drug in human healthy volunteers. You need to check actually whether it is safe or not. You need to do all like toxicity study, like acute toxicity, subacute toxicity, chronic toxicity, all need to be done along with your safety pharmacological study. And even during the clinical development also can be done actually, like as I mentioned, if there is a cause of concern warrant that it is causing some cardiovascular complication, you can go back and do it actually during that time. So this kind of like hierarchy of like safety pharmacology. Core battery, these are the battery are required for filing IND, like a safety pharmacology core battery studies on CNS, cardiovascular, respiratory. Why like these two? Because these are the systems actually which are vital organ, like CNS is a vital organ, cardiovascular is a vital organ, respiratory system is a vital organ. So if the drug is safe on these systems, then only it will be considered for the phase 1 clinical trial. And if there is a cause of concern you are doing with on new chemical entity and there's some effect, you see like drug is showing hypertensive effect, you can do the follow-up study. Why? What is the reason actually why the drug is showing a hypertensive effect? That can also be looked into. Then actually like follow-up studies on the core battery like CNS, cardiovascular, SPD can be done. And the organ system which is not covered over there, you can do supplemental safety pharmacological study on the GI, gastrointestinal tract, ANS, renal, urinary, endocrine system. Those kind of investigations can also be done in safety pharmacology. So this is like cardiovascular, because in our lab actually we do CNS safety pharmacology, we are doing cardiovascular safety pharmacology, we also doing respiratory safety pharmacology. But since actually in this particular lecture, I was just looking into the cardiovascular effects of these COVID drugs. So I just putting into kind of a, what kind of cardiovascular safety pharmacology need to be done. So these 4 core battery studies, you need to record the blood pressure of animal, heart rate, ECG. So now you need to have a setup actually by which you can record. So now kind of setup, like we have kind of a invasive blood pressure recording system. In this system, actually how you can record a blood pressure in animal, you need to initially take the rat or mice actually, and then you need to give a incision, the neck region, and then you have to find a common carotid artery. So in our body, actually, you can find actually there are like 2 common carotid arteries. So there are actually like these major arteries actually which are supplying blood to the brain. Blood from the heart is coming to this one, can going over there and going down. But like this, we have 2 common carotid arteries and 2 vertebral arteries supplying blood to the brain. So you need to isolate this, and you can feel with your thumb like this artery, pulsatile artery. In animal also, we have a common carotid artery, and we isolate that artery and we cannulate using a cannula. Okay, and then using this instrument, we record blood pressure. And in addition, like we also have non-invasive blood pressure monitoring, where you can record blood pressure using the tail of the rat actually, or tail of the mice actually. You can use also like, so this is kind of a non-invasive actually, like here you require a surgery, but in this actually you do not require surgery, but you require training, because you have to keep the animal in this chamber, restrainer. And the chances is that because of stress, actually, these animals shows the increase in the blood pressure. That is why training is required. When their blood pressure gets stabilized, then you go for injecting, administering new chemical entity, and look whether they are changing blood pressure, heart rate, or ECG. And in follow-up studies, you need to do the cardiac output, ventricular contractility, vascular resistance, effect of different endogenous or exogenous agent, that you can see that actually like you inject adrenaline and see actually what the effect is there, and see whether like that is going to enhance the effect of new chemical entity or not. So these ICH S7B guidelines. So these are the guidelines were developed actually when a lot of molecules were getting withdrawn for the market and big loss for the companies. So this ICH, International Council of Harmonization, they came together like Japan, US, and European Commission. Actually, they came together and made these guidelines actually, which applies to identify the potential of a test substance to prolong QT prolongation, and relate the extent of QT prolongation and the concentration actually like that. Those kind of investigations were done. So this kind of a non-clinical testing strategy was applied actually to identify during these kind of studies, the chemical or pharmacological class, like if they are blocking this in vitro IKR, like potassium channel current, actually, they can promote, actually, they can lead to QT prolongation. Or in vivo also you can do using dog telemetry, and you can do and try to find out is there any risk is there or not. If there is a risk actually, then you have to do the follow-up study. So that's why you have to always identify like they should not be, like any molecule should not cause QT prolongation. If they are causing QT prolongation, then you have to stop at this particular stage. You are not going to go for the further like phase 1 clinical trial or so, because the chances is that actually it might be withdrawn during those. Most of the companies, they are doing at the early stage of discovery, okay, and they are developing various different kind of tools actually which can be used. So I think like most of you would have heard about like these electrophysiological studies, like patch clamp studies, okay, ion channel, like single ion channel studies. And that can be because this potassium channel is involved. You can have a system like where you can patch a cell and try to look into whether there is a potassium channel is blocked by that particular drug or not. In vitro electrophysiological study, heterologous expression system like this HEK cell line or CHO cell line, Chinese hamster ovary, or human embryonic kidney, all those kind of cell lines can be used, and you can express hard channels on that actually. Okay, those kind of transfection studies need to be done, and that you can do. Cardiomyocytes can be taken actually because they already have those channels. You can take them also. Purkinje fibers, papillary muscles, perfused myocardium, intact heart can also be taken. And for in vivo, you need to do the QT prolongation of ECG in animals actually. You can use guinea pig or you can use dog actually for that. So we also have this patch clamp setup actually in our department. Actually, one of my scientists is doing patch clamp studies, and particularly on the sodium channel activity, we are looking at in various TRP channel, like transient receptor potential channel. You know that last year this Nobel Prize was given for the discovery of this TRP channel for pain. So this first time this patch clamp technique, manual patch clamp, was developed by Nehar and Sakman, and they got a Nobel Prize for that. And this is considered to be the gold standard, and many times people are using. And in India, I think we might not be having more than 10 systems. So some of the IITs they are having actually, and very few labs having patch clamp setup. But it has got a low throughput, like one molecule in a day, you can do one molecule. But if it's a company, they require kind of a high throughput system. So that is why like high throughput systems have been developed, like kind of patch express system actually, which is there. Now, like you can see that in patch clamp system, like single cell is taken, okay, which can be like your this HEK or CHO transfect with the ion channels actually. You have to transfect with the ion channel, or you can take cardiomyocytes and then patch with the glass electrode and then record the potential actually changes. High throughput QT screens also available actually nowadays. Most of the companies, since they make a lot of molecule and they cannot wait for one molecule in a day, they want like 100 molecule in a day they want to investigate. We generally can go also for high throughput. Many companies, they would be this kind of setup. And these kind of like tracing you will get actually kind of a hard validation using patch express. Different agent which can cause QT prolongations, they were taken in this particular test, and you can see that cisapride, this red color, cisapride is showing, okay. And this green one, okay, moxifloxacin, this is not causing QT prolongation. If you see over here that this moxifloxacin, this IC50 is 39,000 and 49,000 conventional. Okay. However, like a cisapride is 13 and compared to 39,000, and that is why like they cause QT prolongation. And even the receptor binding assays are also available for this one. Isolated heart, like if you have a Langendorf system, and this is also commonly used in many pharmacy colleges like Langendorf. You can isolate the heart and you can check the contractility of the heart. You can put the like electrodes on this heart actually, and you can report ECG also. And you will you expose the heart with the drug actually through the perfusion system and see whether like they are going to induce any effect on this blood. The one of like I think best test is using this dog telemetry, and you can see kind of a dog actually, like these are beagle dog. Okay, they are very docile. They do not bite actually. You can't use these mongrel dogs or other dogs. These are basically for the purpose. And it's not easy to get approval for using dog for experimentation. Actually, you know, you need to get it approval from the CPCSCA from Delhi actually. Your institutional animal ethics committee can approve rat, mice, rabbit, guinea pig, and so on. Okay, but dog actually, you have to go to the approval from the central CPCA committee for approval. Very good, like beagle dogs, cynomolgus monkey, rabbit, guinea pigs can be used, but rat are not suitable model for QT prolongation actually. And these kind of device like radio telemetry devices actually, they need to be implanted in these animals. So these kind of device actually which are available, okay, these can measure blood pressure changes, these can measure ECG changes, these can be used for measurement of respiratory changes or even the brain EEG changes. So you need to implant the device in the animals. Actually, you need to perform surgery, and after that, actually, like you can now these animals are there in the animal facility in your lab. Actually, maybe away about half-kilometer. Also, like okay, they have kind of a telemetry devices like maybe next to your animal facility. You can use kind of a receiver, and you can measure these kind of QT. One of the company DSI USA. They're basically like making these kind of transmitter and doing this telemetry studies. So now you see that the normal ECG, it's like this wave, ECG wave, and the QT prolongation actually, they like delayed repolarization actually what you can see. Late. Action potential prolongation in any of those like cardiomyocytes or maybe Purkinje fiber, you will see. There's a red line actually indicate there is a increase in this one. And the hug actually, this channel block, this sodium, calcium, no. Hug actually, potassium channel actually. And if any drug is blocking this potassium, hug potassium channel, they will cause actually like the QT prolongation actually. Even nowadays, many scientists, they have started looking into the zebrafish model, like can we use zebrafish also, but need to be validated actually. These kind of, because new chemical entity, they require higher amount of new chemical entity, and sometimes some are very costly molecules actually, like very difficult to do in zebrafish also. This I think we have already. Even like there is a lot of market of like developing in silico tool. So there are drug discovery suits developed by many companies. They are using actually, you put your chemical structure and they will predict, okay, it has got a QT prolongation. It can cause cardiotoxicity, it can cause nephrotoxicity. Tools are available. Nowadays, most of the companies, they're trying these tools actually, and if any drug is causing like QT prolongation or prediction is there, they will not take that drug into the development. And most of the companies, you take Pfizer, Novartis and all, they have like very good, like in silico, USAR Workbench, Virtual Talks, QuickPro, Pharm Expert, and many very good softwares. As I mentioned, like this GLP is required actually for these kind of guidelines. OECD principles of GLP need to be adopted actually, and each one of you, if you're doing research, I think you must adopt OECD principle of GLP. So this GLP, like I mentioned, Professor Mohanan, he is like one of the GLP expert, and Professor YK Gupta is the chairman of the technical committee on GLP, and I'm also like one of the members in that committee, and those give the certification for various organization or the labs for GLP, whether they have the GLP certified or not. And in India, like more than 45 labs actually, or around 50 labs, they are GLP certified. And NIPER was the first government lab actually, which were NTC, National Toxicology Center. That was the first lab in the government that was GLP certified. After that, like many other like CDRI, IITR, and many other have got certification. So I think like this National GLP Compliance Monitoring Authority that need to be approached for GLP certification, and these core battery safety pharmacology studies need to be done in following the principles of OECD and in a GLP certified facility. The advantage of GLP certified facility is that the data, whatever we produce in our facility, that is actually basically accepted by other countries. Mutual acceptance of the data is there actually, okay, because that data has to be reproducible actually if it is accepted by other countries. There are like a lot of engineers actually nowadays, you know, like technological advancements are always there. So there are many engineers, they're working and they're improving. They are developing in vitro automated high throughput patch clamp, external telemetry with high definition oscillometry. So now we also have a high definition TVs and all. So they are also like external telemetry with high definition oscillometry, in silico computer modeling, and then human embryonic stem cells derived cardiomyocytes, so that it has more relevance for directly with the human being. They also doing these kind of advances are being there. In addition, I think like we have ICHE 14 guideline for doing the similar kind of studies during the clinical trial, whether it's not only in the animal, whether like it need to be checked in the human being also, like whether there is a chances of QT prolongation or not. These guidelines have been developed, E14 guidelines, and they provide all the details about the QT prolongation studies, actually how it need to be done in case of like these kind of setups. So they have like put this clinical trial, how do you have to enroll the subject, how the safety monitoring and the discontinuation criteria is there, how the design for the thorough QT and QTC studies need to be done, what is the timing of taking ECG. Now this data has to be available electronically. So it's not only like this hard, like you have to give the data to the regulatory agency like DCGI, actually in case of, or CDSCO. Most of you would be knowing like CDSCO approve most of the drug actually in India. And if it's a biotechnology drug product, then even RCGM, actually there's several committees are there. Through that, actually they have to apply to again to CDSCO for approval, and final approval is always by the Drug Controller General of India. That is being done. So there, like you can see that 12 lead ECG need to be done. Ambulatory ECG monitoring can be done. What are different time point need to be taken? And in addition, like the analysis of ECG, how it has to be done. So these guidelines are basically giving the information like how you have to. And you must read, I think, like those who are working in the area of cardiovascular pharmacology on ECG, they will learn a lot of interpretation how this can be done. Like adverse event, how to find out actually related with the cardiovascular, premature discontinuation or the dosage reduction of any of those trial drugs, how need to be done, and the regulatory implication, how the labeling should be there, and what the risk management strategy need to be taken. So these guidelines, E14 guidelines, are basically providing you all the information. Even the pharmacogenetic consideration. So if there is like a kind of a SNP variation, like single nucleotide polymorphism in some of this cytochrome P450, okay, that also would be considered in this particular case. And that case, you can see that these drugs like generally like terfenadine is not being combined with azithromycin. If you see why, because azithromycin, they will block the cytochrome P450, which are basically responsible for the metabolism of terfenadine, and that way it will increase the level of terfenadine, and that will cause QT prolongation. Those kind of like clinically significant drug-drug interactions are generally being taught to the pharmacy students. With this, I would like to summarize that all the anti-COVID-19 molecules need to be investigated for undesirable pharmacodynamic effects. Safety pharmacology like ICH S7A and S7B guidelines evaluate pharmaceutical for cardiovascular safety, and the major role of safety pharmacological studies in continued implementation of ICH S7 and E14 guidelines and introduction of the newer technology is required actually. And future of this safety pharmacological study will not only based on the needs that are defined by contribution of this field to the drug development, but also thorough, creative and explorative direction defined by the investigator. And safety pharmacologists has a great responsibility to protect the public, where caution is appropriate based on potential adverse effect of it. So this safety pharmacology is basically a kind of a young field, and country require a lot of safety pharmacologists actually, which are trained on doing like CNS, cardiovascular, respiratory safety pharmacology. And most of our masters and doctorate students, they are being trained on all those techniques actually. They do like safety pharmacological study of most of the new chemical entity whenever they join NIPER, Mohali for their master program. And in addition, I think Dale View College of Pharmacy, I invite you, and all of you must prepare hard. Like some of you can join NIPER for your master's admission, or we also have started integrated master's PhD program. You are welcome actually. And we have many students from Kerala. To that, I want to see like in coming batch, like some of the students from the Dale View College of Pharmacy should be there. Best of luck to all the students. With this, I would like to thank my force. Actually, students are always like they are the motivation and they do the work. We just present these things, but they are the real worker actually on the lab. With this, I would like to thank actually. Okay, like NIPER or maybe Mohali is not as good as like Kerala, because that's, I think, God's own country. But our campus is still like, we feel is quite a very green campus. And if you come, you will enjoy, like a lot of peacocks will keep on roaming, and very good environment is there. Thank you very much actually, like, and namaste to everyone. And if you have any question, I would be happy to answer.
Very well, which would be palatable to the students sitting in front of you, as well as the members of Kerala Academy of Sciences.
Because of paucity of time, we are not entertaining any questions because we have.
Okay, sir. Yeah, I think a student can write to me. My email ID is ss.sharma@niper.ac.
I'll give them.
Yes, yeah. Please, if you have any question, you can write.
Can I ask one question? This is Dr. Raghu from CSIR NIST.
Yes. Hello, Dr. Raghu. Yes.
Yeah. Do you have a patch clamp set up in your?
Yeah, sorry, actually, I was just on mute. Yes, actually, like, yeah, Dr. Raghu, we have a patch clamp setup, actually, manual patch clamp. So one of my scientists, actually, we are doing on studies on neuropathic pain on the sodium channel. And many of the paper, actually, you can find, actually, from our lab, actually, on this patch clamp.
Thank you once again, Shah, for accepting my invitation.
Okay.
My request, sincere request to you is that you are
connected with pharmaceutical research, you know. So we are in a college, which is an emerging college with a lot of vision. And I hope that you would associate with this college, help them to define the curriculum as well as the other activities that are needed to be learned in pharmaceutical research. So I'm sure that your patronage will be there for this college. And please connect with them and help them.
Okay.
And if time permits, we'll also invite you for a offline demonstration lecture over here so that you can discuss with them lavishly. Thank you very much, and thank you.
Thank you, sir. Thank you, Professor Nair, for inviting me. Thank you, Professor Mohanan also. Thank you.
Thank you so much, Dr. Shyam Sharma, for sharing your valuable information regarding the pharmacological as well as the regulatory aspects of cardiovascular assessments of COVID-19 drugs. Let's now move on to Dr. Vinod Skaria, CSIR, IGIB, New Delhi. Let me invite Dr. A.G. Raghu, Senior Principal Scientist, CSIR, NIST, to introduce Dr. Vinod Skaria.
Good afternoon, distinguished guests from the Academy of Sciences, Central University, Kasaragod, Dale View College of Pharmacy, Thiruvananthapuram. Myself, Dr. K.G. Raghu from CSIR NIST, Thiruvananthapuram. It is my pleasure to introduce one of my family members to give his talk. Before introducing, it is my pleasure to go through his academic credential and research potential. Dr. Vinod is known to me, and we had attended some meetings around 6 years back during the time of OSGD, and his mentor, the former DG of CSIR, Samir Brahmachari, has introduced this concept to popularize the drug discovery, attracting the young mind from Indian scenario. It was a great movement under the leadership of the Samir Brahmachari, and Vinod was one of the prominent participants and player of that program. I still remember some of the speech and some of the activities of the Vinod, and he had attended some meeting in NIST also. I feel he can remember that. Coming to his academic credential, he is a medico from Government Medical College, Calicut. If I say the medico, it is a very rare thing in Indian scenario. Most of the biomedical researchers are from life science or pharmacy. Medical faculties are not attracted to Indian biomedical research, but somehow now there is a improvement in the scenario. A lot of medical graduates and postgraduates are coming. And coming to the research interest of the Vinod, he is one of the stalwart in the precision medicine and clinical genomics. And he is also involved in the genome sequencing project, one of the flagship program of the WHO, and Indian government was also participating, and he was an active participant in the Indian, Sri Lankan and Malaysian genome project. And he is also member of the Hugo Pan-Asian Population Genomics Initiative. Coming to his publication profile, he is one of the best scientists from Indian scenario with good number of publications in Lancet and Nature. And he has guided many students for the PhD in the field of the omics. And I had opportunity 2 days back to meet his director, Dr. Agarwal. He was in Trivandrum for some personal visit, and he was talking about the various activities of the IGAB, and he was also mentioning about the Vinod Sakriya. With these words, it is my pleasure to invite Vinod Sakriya for his presentation. Now the floor is for yours. Vinod, please.
Thank you, Professor Raghu, for the introduction, and thank you, Professor Nair, for calling me into this meeting. It's always a pleasure to be talking about the research that we do. I hope my slides are visible and I am audible.
Yes, sir, you're audible.
Yeah, thank you. So over the next 30 odd minutes, I will briefly provide an overview of what we do in the lab and a journey in terms of looking from personal genomes to populations and coming back to personal genomes in terms of impacting patients with rare genetic diseases. Before I start my talk, of course, there are some mandatory disclosures because we do work with a number of companies across the spectrum of diagnostics and pharmaceutical development. And therefore, many of the things that we do talk also could have implications in the commercial aspects of these companies. But before I start my talk, let me briefly introduce what we work on. We call ourselves as genome informaticians. In other words, we are informaticians who try to understand the genome sequence or try to mine the genome sequence of organisms. Now, there are very different aspects that we try to understand. Understanding many more genomes could have a significant impact in understanding not just the ancestry or the lineages of human population, but also in how these specific genetic structures could contribute to human genetic diseases. And therefore, we could actually build up programs and systems to be able to efficiently use the dwindling cost of genome sequencing, which is happening across the world and is still happening as we speak today. Now, when we started way back in 2008, 2009, this was essentially the map of genomes which are available in public domain. This included 6 genomes, and as you see here from the top panel, were from quite homogeneous populations or less admixed populations across the world. This was the reference genome, the Venter and the Watson genome from Caucasian ancestry, and the Chinese, Japanese, and the Korean genomes of the East Asian ancestry. Now, while there are homogeneous or less admixed populations across the world, there are also quite admixed populations in this part of the world, and this is essentially the Middle East and the Southeast Asia, and where we are from. And incidentally, this is almost a third of the global population, which doesn't have a human genome representation. And that's when we started putting together the genome sequence of the first Indian genome way back in 2008 and 2009, which is announced late 2009. And the idea was to not just sequence the genome in the country, but also to be able to analyze genomes in terms of understanding what are the potentially functional or medically relevant genetic information or genetic mutations which could be derived from genome sequences. So we didn't really stop with the first genome in the country. We collaborated quite extensively across Southeast Asia and Middle East to also sequence the first Sri Lankan genome, analyze the first Malaysian genomes, and we were also one of the founding partners of the Pan-Asian Population Genomics Initiative, one of the flagship programs of the Human Genome Organization. And quite recently, we ventured in the Middle East, trying to collaborate with country-wide genome programs and to also understand the basic landscape of genomes in this part of the world. And today we hold many genetic resources in the lab, which includes one of the largest genome resources for Middle Eastern populations, the Almina, a much recent population scale genome data for Indian populations called Indigen, and a significant large number of Southeast Asian genomes and exomes sequenced from across the world from multiple different countries and researchers. So the question is not anymore whether you can do genome sequence, but rather what do you do with these genome sequences? And that opens up to this enormous possibility of using genome sequences for medical applications. And one of the medical applications that I will sort of delve upon is in the area of rare genetic diseases. And rare genetic diseases are very many in number. There are approximately over 3,000 odd genetic diseases which have been documented in literatures. And this is estimated to cumulatively affect close to around 70 million people in India and around 300 million people across the world. Now, while individually these are rare conditions, many patients suffering from such conditions go through multiple clinician visits, multiple rounds of misdiagnosis, and lose a considerable amount in terms of years and resources even before they arrive at a molecular diagnosis. And that's largely because while individually they are rare, they have been sort of a lesser priority in terms of the medical system. There have been lack of understanding of what mutations in India or what mutations in a particular population could cause this genetic disease. And of course, there's a lack of an affordable and accessible system where these patients can access genetic diagnosis or rather molecular diagnosis. Now, what I will also need to keep you informed is that while genetic diseases are rare, a significant large number of these genetic diseases could benefit from a molecular diagnosis, either by their ability to access very specific treatments available. A significant number of treatments for genetic diseases are presently available, or they could use this information for genetic counseling and the ability to prevent the genetic disease from recurring in the family. And that essentially is one of the cornerstones of genetics and genetic counseling. Now, of course, being in India, there is a great opportunity because we are a sixth of the world population. And unlike the other sixth of the world population, which is China, our genetic pool is quite diverse and encompasses quite a representative populations from across the world. And that is largely because India has been one of the central points of migration out of Africa into rest of Asia, largely Southeast Asia. And more importantly, our population is stratified into endogamous groups. Endogamous groups essentially are groups which marry within the same community. And marrying within the same community, whether it's by caste or creed or by religion, is a common practice which is followed in India. And therefore, many of these genetic diseases tend to be amplified in those small endogamous groups. And much more importantly, compared to the rest of the world, which has been displaced by multiple rounds of famine or by wars in the last century, India has largely been undisplaced in the last 1 century or a couple of centuries. In other words, we still have a close-knit family structure, and we can draw pedigrees which could range 3 to 4 or in some times up to 54 generations. And all of genetics starts with an extended pedigree. And that essentially becomes an enormously great opportunity, because practically that would mean that with a sixth of the world population, we would see many of the extremely rare genetic conditions across the world. And probably not just that, we could have an opportunity to identify new genetic diseases and new genetic variations which have never been documented in literature. Now, sometime in 2015, with my colleague Sridhar Shivasubbu, we put together this program called Guardian. And Guardian stands for Genomics for Understanding Rare Diseases India Alliance Network. And this was funded by CSIR and continues to be funded by CSIR through multiple different programs. And over these years, Guardian today represents, this is a bit older slide, represents close to around 320 clinical collaborators from 70 major centers, making it one of the largest networks for rare genetic diseases, not just in India, but probably in the rest of the world. And the idea was to actually work with clinicians who see conditions which are rare and undiagnosable, and use genomic technology, either by using a genetic sequencing, either a gene sequencing, exome sequencing, or whole genome sequencing, to be able to identify what is really wrong with these patients and families. And in approximately 50% of the cases, we are able to return back a genetic diagnosis to the clinician, who can counsel the patients appropriately, and in many cases, treat the patients accordingly. The rest of the 50%, while they have a genetic disease and we don't understand what is really wrong with these patients, we then take them up for in-depth analysis, either in silico or in vivo or in vitro, using the best of techniques which are available to us to arrive at a diagnosis and to arrive at a solution to the problems these patients face. And the idea is, by doing this over and over again, we could have quite an elaborate insight into the genetic architecture of and prevalent genetic diseases in the populations. And therefore, we could work with clinicians to educate them and make the life of these patients much better. I'll give a few examples on how this works. And over these years, we have sort of created an ecosystem where we could do research, we could help patients, we could educate large number of clinicians, we could enable diagnosis for not just 1 or 2 families, but thousands of families, and help implement policy, and more importantly, to improve the evidence so that policies are evidence-based. And you could read more about this program and this paper that we published way back in 2019. Just to give a few examples of how this happens, this is one of our early cases that we sort of took up in the Guardian program. And this was documented in public news of parents who were asking permission to euthanize all of their 6 kids. Now think of the plight of parents who would want to euthanize their own kids, and that's largely because they have a progressive neurological disorder which was undiagnosed, they don't have a treatment, and they see their kids dying in front of their eyes in less than a decade's time. And as you see here from the clockwise direction are the youngest to the oldest child. The oldest children have become bedridden and pretty much in a vegetative state. And of course, such families are not isolated. There are very many such families who have recurrence of genetic diseases, but nevertheless with no idea on what these genetic diseases are, or no opportunity on how to sort of arrive at a molecular diagnosis and an opportunity to prevent the genetic disease from occurring in the next generation. So we did take up this family for extensive genetic analysis, and we identified that this disease as cystic megalencephaly, or in scientific terms, megalencephalic leukoencephalopathy with subcortical cyst type 1, with an extremely rare genetic mutation, with no estimated frequencies in public databases. There was only one single case reported earlier for this particular mutation from Persia, and no other literature evidence which suggests that this mutation is associated with this genetic condition. Now, while these individual cases are extremely rare, we ventured back into the family and took an extended pedigree. And as you see here, by just drawing up an extended pedigree, we could identify another family with a similar genetic condition, and this child was also tested positive for that particular genetic mutation. And therefore, we went back to the community and did an extensive community survey, and we identified another 2 families with the same genetic condition and the same genetic mutation. And in summary, we surveyed around 100 odd individuals in the particular community, and what we found was really startling. Around 28% of the individuals in this close consanguineous community were carriers for this extremely rare genetic mutation, which doesn't have any documentation elsewhere. Now, how do these patients and families benefit from this genetic test? One, they could access this genetic test to identify who the prospective partners are before marriage, because in a consanguineous community, that is very important. They could access genetic counseling and prenatal services, so that even if they had married a partner who is a carrier, they could prevent the disease from occurring in the next generation by effective prenatal counseling, genetic screening, and of course, termination of pregnancy. But for this, you would require cost-effective tests to be widely available and accessible to the community. And that's when we ventured out into building this cost-effective genetic test, which was run as part of the GOMED program, which my colleague Dr. Mohammed Farooq runs, and eventually is today available widely in the market. And this forms the second founder mutation for this particular genetic disease in India. And in fact, both the founder mutations for this particular genetic condition were diagnosed from India. One was the Wonderknapp mutation, which was diagnosed out of All India Institute of Medical Sciences, and there is the second called the Nalbant mutation, which is also identified in collaboration with colleagues at AIMS. So in other words, for a genetic disease which is apparently rare, you could find a large number of families and large number of individuals who are at risk. You could identify the genetic mutation, you could provide genetic diagnosis, and you could make the test which is accessible and affordable to the community, so that they can act upon the evidence to prevent the genetic disease from recurring in the families and communities. And of course, there are many more such conditions which are undiagnosed, and this is another such case which was referred to us from the Christian Medical College in Vellore. And this individual had recurrent fever over many years, and he has been tested for practically all causes of infection with no diagnosis. He has been on multiple courses of antibiotics, including anti-tubercular treatment for many years without any relief of symptoms. Now, if you have recurrence of fever, one of the rare possibilities that you would need to keep in mind is a spectrum of conditions called autoinflammatory diseases, or otherwise in colloquial terms called the periodic fever syndromes. And this is one such case who also has a family member who seems to have a similar periodic nature of the fever with no diagnosis. And now these individuals do have fever and episodes of fever which mimic infectious causes, but nevertheless these are sterile fevers. In other words, it's not elicited by an infectious agent, but essentially genetic mutations which could activate your immune system to act as if it was facing an invading pathogen. Now, we did the genetic studies for this particular family, and as you see here, a quite consanguineous family. And we did find 2 mutations in this individual. 2 of them, as you see here, inherited from the maternal and the paternal lineages, and therefore in the compound heterozygous state. Now, each of these genetic mutations had an ancestry tracing back to the Middle East, and therefore we were very curious about this family and the ancestry of this family. By genome sequencing, we could establish that this ancestry of the family was indeed from the Middle East. On close questioning, we could ascertain the veracity of this finding that they had multiple generations ago migrated from modern day Egypt into today what we call as India around 54 generations ago, and they formed the community and the population, which nevertheless remained Indian for many, many centuries to come. And this opens up a really big question on what is really the appropriate way to look at genetic diseases, or can we look at genetic diseases elsewhere in the world and therefore draw parallels into communities and diseases which we otherwise find quite rare in such populations. And that draws us to an enormous brotherhood that we have with multiple different regions of the world. This is a small snapshot of the Middle Eastern ancestry and the Middle Eastern brotherhood that we share for many, many centuries. Many of these individuals and populations have come as friends. Many of them have been invited by the royalty to form members of the court. Many of them came as traders. Many of them much later on came as invaders, but nevertheless, they all remained Indian, and they all remained for many centuries as Indian populations. But nevertheless, they have a part of the genome that they bring from where they originated from, or rather where their ancestors originated from, and therefore they also would have genetic diseases which is otherwise prevalent in a different part of the world. And therefore, it's very important there to work closely with such populations where other diseases are quite prevalent, but not the commoner kind of genetic diseases that we find here in India. And we work quite extensively with a large number of collaborators in the region to create one of the most comprehensive resources for genetic mutations in the population, so that we can actually drive parallels on such genetic diseases in our population. So therefore, it becomes quite unique resources for not just India, but also for populations across the world. And that brings to the way technology has been changing. For the last half a decade, we have largely been looking at exome sequencing before, because it was a very cost-effective and fast approach to look at genetic diagnosis. But as sequencing becomes cheaper, whole genome sequencing is becoming much more efficient tool to look at genetic diseases, not just because it is faster and cost-effective, but also the fact that it is all genetic tests combined into one. In other words, the day you are born to the day you are dead, your genome sequence is essentially going to remain the same, and therefore early assessments of genetic diseases could actually be very much cost effective and very much productive if it is based on whole genome sequencing. And of course, there are quite a number of applications where quick turnaround of diagnosis is important, like for example, in neonatal ICUs, in terms of undiagnosed familial genetic conditions, and more importantly, in terms of looking at prenatals for recurrent genetic conditions. But what we need to keep in mind while doing all of this is that while we work quite extensively with clinicians, the very basic paradigm of genetics is that, or genetic practice in medicine is that the clinicians would see patients with genetic diseases. And I will try to turn upon this fact that genetic diseases may not always go to a clinician for, or may not actually go back to seek for medical help. And that's practically because a number of genetic conditions that we know today is compatible with perfectly normal life, but nevertheless with some disfigurement or disability. And one such condition is hypogonadotropic hypogonadism, as is here in the family, quite extensively, 3 generations of pedigrees, multiple members affected, but none of these members could actually be coming to the clinician, but rather was found as an incidental finding in one of the clinical presentations who came for incidentally for some other disease. So in other words, our estimates of genetic diseases, what we call a 70 million or 300 million across the world, is largely based on the fact that clinicians can diagnose genetic diseases. Patients with genetic diseases will come to the clinicians seeking for help, and therefore that by itself is a very, very biased estimate. Now, how do we sort of avoid this bias? And the only way to avoid this bias is essentially to go back to the population and ask this question: from the population, can we identify genetic diseases or carriers for genetic diseases? And therefore, they could be extrapolated to the entire population. And that's when in 2018, we were fortunate to have got funding from CSIR to do around 1,000 odd individuals in collaboration with the Center for Cellular and Molecular Biology and the sister laboratory in the CSIR system. And the idea was to sequence large cosmopolitan populations, not small tribal groups, but large representative populations in major places across the country. And from this 1,000 odd individuals, try to understand what are the prevalent genetic mutations in the population, and therefore derive evidence and policy where we could tackle genetic diseases more effectively in terms of their diagnosis. And of course, there are many other applications to whole genome sequencing, which I could delve deeper on in the coming slides. And one of such applications is to essentially look at pharmacogenomic variants to essentially sort of understand what are the drugs and what are the mutations which are common in the populations which would influence the efficacy of drugs. And as you see here, there are multiple different drugs which could be impacted by genetic mutations, which are quite prevalent in the population. And each individual has an approximately 4 to 6 clinically actionable genetic variant. It is not going to be a problem for everybody because you're not going to take all the drugs available in the FDA drug list. But nevertheless, it's very important to note that when you have a chance or when you have an opportunity to take such medication, your genetic information might become in handy. So that's where we sort of look at an approach where we could inform individuals who are part of this program in terms of what their pharmacogenomic landscape would become in terms of drugs that they can take, drugs which would require dosage modifications, and drugs which they would need to avoid from being taken. The other application for them for genomic sequence is essentially to understand what are the diseases that the country, for example, should prioritize to diagnose and treat. And one such subset of diseases is intellectual disability. Intellectual disability is a very prevalent clinical manifestation. Many of them could not be genetic, but a significant number of those intellectual disabilities are caused by genetic mutation. And a subset of these genetic mutations are causing diseases which are treatable by very specific molecules. So you could understand from the carrier frequency in a given population what are the prevalent genetic diseases, and therefore we identified a total of around 23 genetic mutations which qualifying to become called as a pathogenic genetic disease. You could look at the frequency of these genetic markers across the population and ask this question: what are the diseases which are prevalent? And to surprise, you find that there are many genetic disorders which we thought were not prevalent, but nevertheless are quite prevalent in the Indian population. And one such example is Wilson's disease, which my colleague Dr. Binu Kumar works upon. And in total, one in around 25 individuals, around 4% of individuals in the population are carriers for one or the other of treatable causes of intellectual disability. Now, these are the prevalent causes of treatable intellectual disability, and therefore we can use this approach to actually build forward cohorts and diagnostic tests to diagnose and treat such genetic conditions. And my colleague, Dr. Binu, who is here, has now actually taken it forward quite extensively to create one of the largest cohorts for Wilson's disease, one of the most prevalent treatable causes of intellectual disability. And over years, he has actually now created a much significant cohort where we can impact now patients either through genetic diagnosis, through genetic counseling, prevention of genetic conditions recurring in the family, and more importantly, early diagnosis and early treatment, because there's a cheap and effective treatment option available for Wilson's disease. And early diagnosis can actually have these children live a near perfect normal life. We could also build tools and techniques which can now do genetic screening across populations, especially for prospective parents, for very prevalent genetic diseases across the country. Now we have a product now in the market which can screen for around 1,700 genetic diseases and over 10,000 prevalent variants in the country. And now, more importantly, as we adopt genomics, as many other diagnostic tools have come in the past, it's really important to actually keep pace with the emerging evidence that is accumulating in genomics. And therefore, you need to have systems to communicate this information in a relevant format to patients through a secure, privacy-protected, scalable, and clinician-enabled and point-of-care methodology. And what we launched in 2019 was this card, what is called the Indigen app and the Indigen card, where we can actually use the ubiquitous mobile devices to be able to interpret genomic information and enable the participants of the Indigen program to access what is really there in the genome sequence and make informed guess, or rather communicate this information to make informed guesses so that they can, so for example, prevent adverse drug reactions to certain drugs or make the reproductive choices based on what is in there. And more importantly, this is clinician enabled, and therefore we need to train a large number of clinicians, which we have been doing over the last couple of years. So in summary, before I close, what I can suggest to say is that we can create an ecosystem for accelerating genomics and genomic implementation in the country, right from a single sequence of human genome a decade ago. Now, today we have thousands of human genomes which can drive epidemiology. We have created a rare disease program which has benefited thousands of families. We constantly educate clinicians over and over again. We enable affordable and accessible genetic tests to multiple different programs. And we work with the counterpart industries, whether it's the diagnostic industry or the pharmaceutical industry or patient support groups, to accelerate development of newer diagnostics and newer therapies which are affordable and accessible, while we do our core research in terms of building not just diagnostic, but also understanding the mechanism and biology of genetic conditions. I think I'll stop there and take questions, but before that, let me acknowledge a lot of people who made this possible, a lot of students in the past and the present, and of course, consistent funding over the last 1 decade from CSIR through multiple different programs and multiple different grants. Thank you very much. If you have any questions and if there is time, good take them. Yes, sir.
Open for any questions from the audience. Thank you, Dr. Vinod. We are very fortunate to have a very comprehensive presentation, particularly on genomes from personal to corporations and back. We are very happy on behalf of the organizers. We extend our heartfelt thanks for accepting our invitations and delivering the lecture. Thank you very much.
Thank you very much. Always my pleasure.
Thank you. Thank you.
Thank you so much, sir, for sharing your valuable information regarding various genomic aspects in the present scenario of study of genetic diseases. Before further ado, now let's break for the lunch session, and we will all assemble back by 2:50 for the post-lunch session.
This meeting is being recorded. Let me invite Dr. A. G. Pandurangan, former Director, KCSTE, GNTBRDI, Palo, Thiruvananthapuram, to introduce Dr. Anugya Bhatt.
All of you, dear students, and welcome to the and welcome to this session. Actually, the session will be handled by Dr. delivering on 3D bioprinting, the promising technology in regenerative medicine. It is a very important, actually emerging topic actually for the students of, particularly the pharmacy students, because they are the people who are going to handle the future, both the medicine and the therapeutic value materials. So I just want to introduce you, madam, to the audience of the benefit of the audience. Dr. Anagya Bhatt is the scientist in charge of the division of the thrombosis research, Sri Trinal Institute of Medical Science and Technology, Trivandrum. She did her PhD at Jiwali University and postdoctoral research at Sri Trinal Institute of Medical Science and Technology. Her area of interest includes 3D bioprinting, proteomics, blood material interaction, and stem cell research. Almost all these fields are very emerging and very important, particularly in molecular medicine, actually, in fact. She had enormous international publications in her credit and filed 6 patents in her credit, actually. She is a member of various scientific bodies, such as International Society of Stem Cell Research, Society for Biomaterials, Fellow of the Society of Applied Biotechnology, Society for Cardiovascular Research, Cytometry Society, and the International Society for Atherosclerosis Research. So we are very fortunate to have you, ma'am, for today's session, and I hope we would like to hear you the latest bioprinting about to know about, and it will be more useful for the students. And thank you very much for accepting our invitations, and we look forward to your great lecture, ma'am. Please go ahead. Thank you very much.
Thank you, sir, for the kind introduction. And I would like to put on record my sincere thanks to the organizing committee for inviting me and giving me this opportunity to share my thoughts and my work with this young minds. So I would like to share my slides, and I would also like to know, am I clear? Am I audible to all of you?
You're audible.
Yes, ma'am, you are audible.
Thank you. Hope my slides are visible.
Yes, ma'am.
Okay. So I would start today's talk as the topic is 3D bioprinting, the promising technology in regenerative medicine. And as I have been introduced, I belong to Sri Chitra. So the talk as such contains, before we go into the detail of regenerative medicine or 3D bioprinting, we should know what is regenerative medicine, what is 3D bioprinting, and how it is connected to the regenerative medicine, how this technique is being used, and what are the applications this technique has, what type of printers we have. And as I'm working on skin tissue engineering, I will be just giving a very brief how the skin can be regenerated using this technique, and where do we stand as of now. When I say where do we stand, I mean globally where India stands. What are the limitations and what is the future of this technology? So just to introduce about the regenerative technology, I know most of you will be aware about, as the name suggests, regeneration is to regenerate something, something which is getting damaged, something which can be repaired. We need to regenerate it, right? And for regenerating something, you need to have the source, the cell. When we talk about the biological samples, we need to think about the cell source which can regenerate that particular tissue. So if a tissue is made up of a particular type of cells, to regenerate that tissue, we need either that cell or a cell which can be converted into that particular type of cells. And this technology was basically thought, or basically was evoking when we thought that there are so many diseases which are degenerative diseases, like neurological diseases, brain disease, Alzheimer's disease. These are the diseases which are degenerative diseases. So when there is a degeneration, can we regenerate the tissue which has gone? Like we know liver has a high regenerative capacity. So can the all tissues can be made like that? And even liver, once it is damaged beyond a repair, can't repair by itself, right? So we need to have something in our hand by which we can regenerate the tissue. So the cell sources, as by you now you know that if we need to regenerate a tissue, we need a cell which can proliferate, grow, and make that particular tissue. So either you need to take the cells which are tissue specific, like if it is a skin, we need to take skin cells, keratinocytes. If it is liver, we need to take hepatocytes. Or you need to take a cell source which is stem cells, which can be converted into either of these cells, right? Stem cells are mainly used in regenerative medicines because they have advantage that they can be molded in any type of cells. Now, when we talk about stem cells broadly can be said adult stem cells and embryonic stem cells. Now, embryonic stem cells, they have very high capacity to proliferate as they are from the embryo, they have pluripotency. They can be converted into any lineages, but the ethical concerns using the embryonic stem cells are much higher compared to the adult stem cells, which can be taken from any adult tissue, for example, from fat tissue like mesenchymal stem cells. So the choice of cells also lies either we can go for the stem cells, which can be converted into any of the required cell type, or we need to use a cells which is specific to the particular organ or tissue we are thinking to regenerate, right? Now, when we talk in terms of regenerating of the tissue, we can't forget the two very important names who actually gave us the directions or the dimensions of the regeneration. The first name is James Thomson, who first time isolated the stem cells and gave the concept that it can be converted into any cells or it can be isolated. And second is Shinya Yamanaka, who decided that even if you don't have a stem cells, or cells can be programmed to become a stem cells, like induced pluripotent stem cells. With all these names, now we know that when we have cells with us, that means you need to isolate if we need to regenerate a tissue or if we need to go for a regenerative medicine or an alternative therapy, we need to have the cells. We need to manipulate the cells to form what we need, and then we need to put the cells back to the patients. Now, the conventional approaches in the regenerative medicine, like tissue engineering, what is being used till now, which uses the scaffold, where you put the cells into the scaffold in a two-dimensional structure, which is much more different from what is being found in our body. That means in the three-dimensional structure which we have in our system. In our body, the cells are not lying, right? They are embedded into the extracellular matrix, which provides it a three-dimensional structure. So this was the point when it was thought that can we create a tissue, a structure exactly as it is there in our system or in vivo. And if we can do that, we will be able to overcome the shortage of organ which is available. We all know there is a huge demand of all the organs, whether it is kidney or liver or even the skin in case of burn. And even when the gold standard methods for organs are organ transplantation, when that is being done, it has a very high rejection. So can we have some way, either by using the patient's own cell or by taking the stem cells, which has least immunorejections, can we create the organ which exactly mimic the in vivo conditions? This was the reason what led to the 3D construction. And when we talk the 3D construction, we cannot forget the name of Dr. Anthony Atala from Wake Forest Institute, with whom we do have, even Chitra do have a collaborative work and we got training from him, our people. So he was the pioneer who decided that this organs, the regenerative medicines, can be clubbed by then, like this is, I'm talking about 1999, where the 3D printing, which was basically used to make the toys, that if this technology can be converted into a bioprinting, it can be clubbed to regenerate the organ exactly the way they look in our tissue or in our system. So Anthony Atala basically took the cells from the gallbladder and he created a three-dimensional or artificial gallbladder, which was implanted in the animals and even in the humans in the later stages. So this was the time point at 1999 or 2020 years back from now, when the 3D bioprinting, the concept of the 3D bioprinting was started. Before we go into the detail, I'll just introduce you what is 3D bioprinting or how it originated from the 3D printing. 3D bioprinting is basically an additive manufacturing. When I say additive manufacturing, what do I mean? You keep adding the layer and you will have your final structure. That is how, even in the nature, if you have seen the bird nest, bird will make their nest by a 3D bioprinting technology or the 3D printing technology. They layer one by one and finally they have a particular structure. Now this technology from nature, which is bottom up approach, that means you keep one layer, second layer, third layer, it's a bottom up approach, you are making it up. Finally, if you have a design, you can keep layer by layer your cells with your extracellular matrix and can make a tissue. This was the whole idea of the 3D bioprinting or 3D printing, when you keep without cells any material you are keeping to make the prosthetics or toys or anything layer by layer when you make the structure. So when 3D printing or bioprinting was starting, one thing which we should not get confused, whether it is a 3D printing, bioprinting or additive manufacturing, all this just a name of a single tech, like three different names of a particular technology which work on the same principle. You have a structure, a design, a liver, a heart, an organ, a skin. And then you know that how can I construct it? If I need to layer this, how do I construct it? Then you layered it using your ideas theoretically or software in practical now in the latest research. And then you program this, that this is how I need to print my structure. And then finally you get your organ or your tissue. So before I jump directly into the latest of 3D bioprinting, how it started was in 1984, the 3D printing was started, the basic by keeping the basic idea of making the toys or infrastructures a fast, rapid, reproducible infrastructure, machine or cars or even houses, which went on until 1988, and then later on in 1999, the Charles Hull, a very known name in the 3D printing, who made the models. He decided how it has to be done. You make a model, you design that, you sliced it, and then you printed the exact model. So the replication can happen. So the concept which came into the mind of probably that time Anthony Atala in Black Forest in 1999, that it can be reproduced. We can have a repeatable, reproducible models. So if it can be done using the plastic raw materials, can it be tried with the biological materials? And that is how 3D bioprinting started. And very recently, though from 1999 tissues and organs were thought, very recently it was started using into the different orthopedic implants or the other implant, like in the medical field as well, the 3D printing. And then in by keeping the 2019 or 13, 14, like if we can go around 12, 13, from that year, more and more work on the bioprinting was initiated. In Chitra, we started 3D bioprinting in 2016 when it was in a very naive phase, and different organs were tried like liver, skin, cornea, different organs were tried. So this is, and even now, even today, 3D bioprinting, it's in a naive phase, but the advantages are very clear. You can create a tissue, a model, which is very similar to your in vivo system model. So as of now, liver, kidney, gallbladder, skin, cornea, so many organs has been tried and proven apt as well as the in vitro is concerned. There are few things which has gone even in vivo, even the patients, it has been implanted like gallbladder and all. So it is long way, which we are crossing slowly. Coming to the technique per se, as I have already told, you need to have a design. When I say design, like if a patient comes with a malfunctioning heart, the heart image can be captured, a CD of the image can be taken. And exactly on that particular size, like kid's heart will have a different size than the adult heart. So exactly based on that, the particular cell types can be chosen, or the different, if it is being taken from the stem cells, it can be taken. The organ can be designed, sliced, and print. So if I want to put in a definition, 3D bioprinting can be defined as a form of additive manufacturing that uses cells and other biocompatible material, which is known as inks, which is basically your extracellular matrix like collagen, gel, whichever is present in our system. We have laminin, collagen, any of these things can be chosen as a bio ink. And then this is being used to print living structure. And once this living structure is matured, it can be kept back or used for the treatment of the patients. So the whole process, if I want to describe you, this is an example with the skin cells. You can isolate the cells from the patient's skin. If you have a burn patient or if you have a skin damaged patients, you will know that clinicians have a time of say 13 to 14 days when they do the debridement, when they clean their skin before they do the skin grafting, at least 5 to 7 days of time frame. So and when they do the skin grafting, they take a huge amount of skin from the other side, which leads to the morbidity, the patient, the bedside morbidity. So to avoid that, a very small patch from the patient's skin can be used to isolate the different cells, or even the stem cells can be used. This cell suspension can be put together with the hydrogel. When I say hydrogel, it's nothing. It could be alginate, or it could be any biomaterial which is found in our system itself. Even there are studies where they have decellularized, they have taken the extracellular matrix for a particular tissue, and that is, the cells have been removed, and the same thing is being used as a hydrogel material or bioink. Then it is being printed in the design what we need, and then it can be pushed back, because it is the process will be fast, reproducible, repeatable. It can be pushed back or it can be set back into the patients. So going into little more detail, this how this 3D bioprinting can be done. There are different ways and technology which is being developed on the basic principle of the 3D printing, but by keeping the cells and biological materials in mind, because cells are very fragile, so you have to be more careful with them. So the recent technologies which is being used for 3D bioprinting are laser based, where the laser beam is used, extrusion based, where the pressure is used, or inkjet, which is very similar to the inkjet or inkjet printers which we have. Now, to give you the brief detail, in the pressure-based system or extrusion-based system, the bioink is extruded, and you need a thin filament, as you can see in the first left corner. Then the other one is the inkjet, where you need a droplet printing, the drop by drop it comes. And other one is stereolithography or laser-induced, where the design is printed, and that when the laser light hits your biomaterial, it will be dropped in the design which we want, or which is already being designed. So I little bit on the detail you can see here. In the inkjet printer, the very tiny drops comes. So you need a bio ink which has a low viscosity so that it can flow, but at the same time it should solidify very quickly. And these droplets are so tiny that you finally, when it makes your tissue, you won't be able to see that it is a single droplet, exactly in the form as you see when you see a print which comes from inkjet printer, right? It comes drop by drop. Okay, but this technology, you need a cell density is a question, or you need a lot of optimization there, because the cells are embedded into the drops in which they are passing through. At the same time, this can be used for the small patches, like if you need a quick skin patch, it can be used, but for the large patches, this technique is not that easy. So the another one is laser based technique. As I have already told here, the biomaterial is coated on a paper, and then laser light hit that, and based on the design we created, the laser from wherever the laser is hitting, the biomaterial from that will drop down, and on the paper, on the below substrate, it will make the design we want. Now in this case, the speed is very low. uh, Creating the multi-layer structure is tough, because once the laser light hit and biomaterial has gone, the making the another layer is very tough. So it has a limitation that multi-layered or the complex structure cannot be print. And then it can be used when you have a singular application and you need very precise, the best resolution, this technique can be used. Now, the most common technique which is used in case of bioprinting is the extrusion base. The reason is you can create the large structure. It is a flow, it is like a thread like structure is what is getting printed. So any design you want to make is much easy. The only thing about it has is it because it uses the pressure, the cell dies. You are having the cells in your bioink, so there is a high chance that your cells viability will be low. That is basically overcome either by using the higher cell density or creating or optimizing a hydrogel formulation or a biogel formulation, which can be extruded at a low pressure for the pressure which cells can survive. This has low resolution, but it can be used for large structures. So as of now, when we are using the extrusion-based bioprinting, and most of the structures or the constructs have been are using the extrusion-based bioprinting. Now, just to brief you, now when we have dealt with the 3D bioprinting, what we need if we want to regenerate an organ using 3D bioprinting. First, we need to know which organ are we thinking, which organ we want to bioprint. Based on that, we need to decide what type of cells we are using. When we decide the cells, we need to know what extracellular matrix this particular organ has in vivo and how can we create that extracellular matrix or bioink or hydrogel, one name for all these things. What biomaterials we use to create that, and then what is the optimum way to construct, whether extrusion or whether it is a thin layer, whether we need high resolution, what is the optimum method to construct this, and after construction, what is the functionality of this particular organ, because the whole concept is you should have something which is functional, right? So the 3D bioprinting gives us the over advantage over the conventional structures will have a inbuilt, like that is top up approach, where from the top you have a scaffold and you put the structure. So it is a porous structure, but it doesn't allow diffusion of the uh, culture media all through. But 3D bioprinting will allow you exactly what we want, diffusion of the material, reaching to the even to the base of your structure. So that is why the most used technology in the regenerative medicine as of today. Now, when we come to the bioink, as I already told you, bioprinting needs two important things: bioplotter, cells, and bioink. Bioink includes cells and the biomaterial. Now, bioplotter, that means the bioprinters, we have already discussed. So now the remaining things is the bioink and the cells. Cells, I have already given a brief, we'll have little more. So the bioink, whatever you are using, should support your cellular adhesion as it happens in our body, cellular proliferation, differentiation, right? So there are so many materials which is being used as a bioink, like hydrogels, natural and synthetic. This hydrogels has an ability that they can be cross-linked to make it solidify. So the most common natural hydrogel is being used like alginate, agarose, collagen, hyaluronic acid, fibrin, cellulose. Even as I was telling you, extracellular matrix from the tissues of the different organism as well, or from the same if you have a damaged tissue there. So the selection of this hydrogels depends on the which organ we are looking for gelatin. So which organ we are looking for and what should be the components of this hydrogel formulation. What is the component of the ECM there? We can modify this hydrogel or to increase the properties, like natural hydrogels may not have those properties or the mechanical strength which is needed for your tissue or organ, or soft or hard tissue, like the requirement will be different. So you can use either the synthetic material as well, which is biodegradable, or we can use the combination of both to provide us what is needed. The whole idea or aim in regenerative medicine or in 3D bioprinting is whatever ECM components we are providing, they should dissolve or degrade over a time, and it should allow our natural cells to grow, synthesize their ECM and overtake this the phenomena or the bridge which we have provided for cells to grow. So in the synthetic, the most common are polycaprolactone or polyethylene glycol or the chloronic acid. So this particular bioink or any bioink when you design, you need to have a multidisciplinary approach. You should know that your bioink is biocompatible. It should be printable. It should have a particular degradation so that the time frame in which your tissue will regenerate or the surrounding area which will allow it to regenerate fast, by that time this your bioink should degrade. It should be structurally porous so that it allow all the diffusion of your blood or any nutrients which is required for cells to grow. It should have sufficient mechanical properties and the viscoelastic properties which is resembles close to the in vivo organs or the structures what is being planned. Now, if I put the whole process, you have a bioink which need to be optimized for its printability, its cross-linking, what are the cross-linking agent you are using, what is the mechanical property, how close it meets to the, how it gets degraded, and whether those degrading products are harmful to your cells or not, and whether it provides cell adhesion or not, whether it allows the nutrient transportation or not, and enables your cells to grow and grow. And this needs some type of optimization process. You can optimize printability by cross-linking your hydrogel with different concentration. Like for example, for alginate, you can use calcium as a cross-linker. Different concentration of the calcium can give you a soft tissue bioink or a hard tissue bioink, right? And you can optimize how much should be the exposure time, how much should be the pressure on IM printing. So the initial work for optimization of a bioink, because this is the most critical part of your whole system, because if you can print a good hydrogel which is stable and which provides your cells to grow, and then only you will be able to create or regenerate a tissue. So this is the most critical part of 3D bioprinting, to choose a correct material and then optimize that particular material for your requirement or for your tissue which you are planning to print. And then as you keep this material, the time goes, your cells will grow. This material should be able to hold your cells. At the same time, the regeneration should be slow enough so that by the end of the time frame, you have your tissue in place. So briefing it, in your bioink, you should have a bioink which is non-toxic, biocompatible, cell-friendly, printable, should be quickly gellable, controlled viscosity so that you can design your porosity and you can modify your bioink, and its degradation product should not be harmful. Now determine the cell types. As I have already told you, that determination of the cell type depends on what organ we are thinking. But in each tissue, there are functional cells and there are supporting cells. Like in case of skin, fibroblasts and keratinocytes are the major functional cells. Like keratinocytes will support the barrier function. Fibroblasts will support the ECM synthesis. Same thing in the liver. The hepatic cells, the hepatocyte cells are the main functional cells of the liver. The other are the parenchymal cells. So when we are creating a complex structure, as of now, as we are in the naive stage, we want to create the structures which are not that complex. And the primary requirement of any organ or tissue is the function. And we expect that when these tissues or organs are being put, the surrounding, the in vivo surrounding will allow it to become the natural, become a part of our system and become the natural. So as of now, the cells which is being used are basically the functional cells which perform the function. Now these functional cells could be from the tissue specific, like you have taken it from the tissue, or it could be from a stem cells which you have differentiated, proven that it is into this lineage and it's functional similar to the cells of origin. Now here we have to be concerned what cells we are choosing, whether they have strength to go or they are not totipotency, so they shouldn't result into the cancer or something like that, or rejection and immune responses, the cells should not cause any rejections. So those should be keep in mind when we are choosing the cells. At the same time, we should provide, as I told, when we do the extrusion-based printing, we do pressure. So we are actually putting cells into stress. And when we are in stress, the way we behave in the similar way cells will also behave. So it is important that we provide nutrition to the cells in terms of medium growth factors. We keep the optimum temperature, what is needed by the cells, and we provide the oxygen, the gas exchange, which is required for cells to grow. That is why the porosity of your bioink is very critical and important. That will allow, that can control at least the nutritional flow and the gas exchange, the temperatures we need to maintain. Now coming to the application of 3D printing, mainly as our focus is on the bioprinting. As I told, the one part is organ, the another plant is the medical application or the bio or the synthetic parts, like even the plasters are coming now, or even the treatment regimes which cannot be handled by the conventional approaches. Like if there is a bone defect which cannot be corrected by the conventional approach, 3D printing is paving a way there itself, there also. So tissues and organs are one part, and medical applications are another part. There are so many examples where the badly fractured bones, or there are stories of animals as well as the humans when the conventional approaches failed, the 3D printed approaches were used to treat the patients. Like you can see a small girl here who had a bone fracture from his neck to hand, and which was not which was not repairable through the conventional approaches, but 3D printing helped there. Coming to the organ, as of now, as I already told you, the 2-dimension printing will not allow you what is needed for your organ to be functional, fully functional. So the requirement is to have a environment where your cells could be rearranged them as they are in vivo in the septal arrangement. They can contact each other, the cell-cell interactions are more, and this all can be provided only by the 3-dimension printing. So coming towards the end of my presentation, 3D bioprinting in regenerative medicines, it has the current what is being done is we are creating the tissues or organs, we are printing them layer by layer, and they are functional tissues, organs. And these are used basically for the drug testing, like pharmaceutical company, as sir was telling, there's a good crowd on the pharmaceutical. So I will just put few words on that. There's so many drugs which have been cleared. Actually, the animal experiments gets failed just by the liver toxicity when it comes to the human. So this is the easiest way that you can create a human liver, mimicking a small artifact of the human liver, which can be printed using the human liver cells, which mimic your liver function, and then so many cosmetic drugs can be tested. So it reduces the animal testing. At the same time, it helps you to screen thousands and thousands of drugs, which can finally, whoever is cleared from here can move to the next step. And we have also created the non-transplantable tissues and vessels, which is into the research stages. So many, it is also helping into the different surgical procedures, the very critical surgical procedures where the imaging has been done and the surgery is first done as a 3D in the 3D printed organs, and then it is being done in the final organ. In the near future, we can hope, we can think a tissue with the cells can be put into the human, and it can be used. Small organs like skin or cartilages, those things can be put. And in the far future, we should have off the shelf. That is what is the dream, and that is what is the requirement, that the way organ demand is there, and then the long gap between the organ demand and the supply, if we reach somewhere where we can have off the shelf organ, we will be able to save lakhs and lakhs of life. That is what the dream probably for all the people who are working in this field, that at least one organ means you can save a lot of life. So the highlights: bioprinting is a powerful technology in tissue engineering and organ fabrication. It is emerging, like I told you, in the drug screening, especially in the cancer research or even in the drug toxicity research, because even in cancer, there is a huge, all the drugs which is being used are used based on the data we have from the European countries or from the US. There is no data for the Indian population, and our population is much different. So there is no drug, and it is not known that whether any particular drug is specific to any type of cancer. So there is a huge research potential there, and this 3D printed different organ models can be used to screen those drugs and find out whether any drug is specific to any particular type of cancer. And it is transitioning to the pharmaceutics and high throughput screening. There are thousands of merits for this technology. We can, in the far future, as I told, we can think about the artificial organs, which could be made from the patient's own cells. It could be a personalized medicine. If we are using the patient's own cells, there will be no host rejections. There won't be any requirement of the immunosuppressant drugs. You know, that when there is a transplantation, the patients have been put lifelong on the immunosuppressant drugs. That also increases their susceptibility to the other diseases. So even COVID time, we have known that so many patients who were having kidney transplanted or different organ transplanted, they were more susceptible to the COVID because their immune system is weak. And most importantly, there won't be any queue, any line for the organs. If there is a requirement, there is an organ. If we could reach or achieve there, which I believe is the future of 3D bioprinting, it will be a great achievement of the science for human. Now, there are another things, the cost, though we say that this is a huge good technique, but we know that bioprinter are costly, and the country like India, cost is still a major factor as far as the treatment is concerned. Now, stem cells, if it is a patient's own cell, there is no issue. If we are using the stem cells, still there are like debate on that, use of that. What is the possibility of more expensive than regular organ? Like that is the main thing. And so far, vascularization, immunosuppression, if we are using another stem cells, all those things need to be thought of before we can dream a real organ. But I believe that all these things, as of now, vascularization has been initiated. So many research projects have been initiated on the vascularization. So I believe in 15 to 20 years from now, we will be able to overcome all these problems. And even when we say the cost, anything when it is launched new, we can take a simple example of mobiles. It would have been very costly, like 30 years back from now, when people were not thinking about mobiles, or 20 years back when mobiles were launched, it was very costly. A simple mobile was very costly. Now you can see the mobile cost has come down. So as the technology progresses, the cost comes down. So that could be things. This is just to show you that the market potential is huge in the research field, and it is growing, and India also have its own role there. And that is what I say, that this is particularly for skin, that the sector is growing huge. So if the growth is huge, then we can expect that cost will definitely come down. Now, just to brief you about our work, skin is the largest organ, and we have already discussed. So it is prone to the what you say, the damages which it can happen. And other than that, the burn, the skin injuries, the diabetic foot ulcer, there are so many things which causes the skin injuries. And the gold standard for skin is in the 3rd degree burns, or when the skin has been lost huge. The golden standard is the skin grafting. Now, when you do a skin grafting, a patient who is already lost his skin, you are again taking skin from the different place and putting it back. So we are giving another injury to an injured patient. And sometimes there is not sufficient skin is available with the patient. He is so much of burn. Thus, if we can reproduce or create a skin, it could have been, we can satisfy both the clinical as well as the industrial need. Clinical need, I have already told you. Industrial need means so many cosmetics now, the animal testing is banned for the cosmetic. So we are the guinea pig now, whoever is using the cosmetics, because this directly comes to the consumers. So, but if we have any skin, artificial skin or skin substitute, like there are already Lenovo, there are so many companies which have collaborated with each other to do this 3D bioprinted skin as their substitute for cosmetic testing or the drug testing. So this was the approach which we have used. I have already told you, we have optimized the bioink, then we printed it using the different skin cells. And the impact of this 3D bioprinted skin construct. It can be used in the burn patients or the skin injuries. It can be used as full thickness or partial thickness, or it can be customized. Even in future, there are reports where they say that skin can be printed directly on the patients, and high acceptance, low graft rejection. It can be used for cosmetic trusting, precise, accurate, whatever is the wound size, whatever is the wound area, accordingly it can be printed. And the most importantly, it can fill the widespread gap between the organ demand and supply. So this is brief work, our work in very brief. We have printed, optimized the bioink formulations. This is not the animal or human skin. This is the skin which we made from the hydrogels and using the skin cells, and then we grow them, and you can see it has epidermis and the dermis. It has lineages. So this was published. This is our couple of publication. If any of you are interested in going into the detail of 3D bioprinting, this is our very recent work. You can go through it. And lastly, the take-home message for all of you: 3D printing technology has evolved and expanded its footprint from conventional manufacturing field to the biomanufacturing, and it has a great promise to regenerate human organs. Choice of bioink, as I was telling you, it is very critical and most important parameters. There are wide varieties of approaches: extrusion-based, inkjet-based, and laser-based, but the most commonly used is the extrusion-based. And future of 3D bioprinting actually lies the successful off-shelf tissue organs, like you order and take it from the shelf, and then it can be readily available for the transplantation. It can be customized based on the patient's requirement. Though it's a long path, but it is getting short day by day. So thank you so much. Design, print, and regenerate. Thank you. So I'm okay for whatever is the questions to me.
Thank you, Dr. Anakia. So if you have any questions from the student side, otherwise we can also put your questions in the chat box.
Okay, so far I don't have any questions. Is there any questions?
Yeah, I will ask one question. Dr. Anakia?
Yes, sir.
Successful story in regenerating the uterus cells, which can be successfully transplanted to the reproductive age woman.
Pardon, sir, I didn't get. Can you repeat it?
Can you hear me first?
Yes, I can hear you. Yes, I can hear you now.
Is there any successful event and could regenerate the uterus cells and then transplant to the women of reproductive age?
No, sir. So far, no. So far, it is basically being done on the liver, kidney, urethra, gallbladder, those type of organs, skin, those types of organs have been tried and it is being done as far as the 3D bioprinting is concerned. But they are exploring, like there are different groups who are exploring all the possible fields.
Because nowadays, because of our work experience and pressures, there are many instances when young women, because of cyst formation and all, they are losing their uterus, and it is creating a lot of problem in the family life. So I think regenerative medicine can be one of the way we can able to overcome in future this problem.
Sure, sir. Yeah, it is a good field, and what you said correctly, it is a problem of so many, mainly women's are a huge population, so it can be definitely worked out. And probably I am not aware. There will be group who is working. I need to go through in detail. I am working on a skin and liver part, so probably my knowledge is limited. But definitely I'll go through it and I'll see whether some group is working or whether we can initiate. Thank you for your suggestion.
Thank you, Dr. Anagia. Thank you. Very illustrious presentations. Thank you very much.
Thank you, sir.
Thank you, ma'am, very much. Actually, it was an excellent, comprehensive presentation, opening up a completely new area in science and technology, especially to the student community. And so, on behalf of Kerala Academy of Sciences, as well as Central University of Kerala and Delhi College,
Thanks to you. Thank you very much.
Thank you. Thank you.
Thank you, ma'am, for the wonderful presentation on 3D bioprinting. And once again, thank you, ma'am, for throwing light on the most promising technology in regenerative medicine. It's my pleasure to move on to Dr. Ruklandi De Alves. Let me invite Professor Dr. Annie Abraham, Joint Secretary, Kerala Academy of Sciences, Thiruvananthapuram, to introduce Dr. Ruklandi De Alves.
Am I audible? Ruklandi madam, am I audible?
I can hear you now. Yes. Yes.
Good afternoon, it's my pleasure to welcome Dr. Ruklandi De Alves from UKUS Medical School, Singapore, who has graciously joined us to deliver the invited talk of today's program. Ruklandi completed her PhD in microbiology and immunology at the University of North Carolina, Chapel Hill, USA, where she the human antibody responses to dengue virus. Further, she acquired training in epidemiology at the London School of Hygiene and Tropical Medicine and worked as an epidemiologist at the Oxford University Clinical Research Unit in Ho Chi Minh City, Vietnam. She then joined the Viremics team, where she is currently pursuing projects looking at the human antibody responses to viruses, both at a mechanistic and population level, antibody responses to flaviviruses, immunoepidemiology of antibody responses to natural infections, preclinical and clinical vaccine development, antibody responses as a tool for surveillance of infectious diseases. Madam, please.
Thank you. Thank you for that kind introduction. And thank you for inviting me. It's really a pleasure to present. I did get a bit carried away, so I packed this with a lot of data. I'll try to sort of explain it through and let's see how it goes. So the talk that I'm going to give to you today is about COVID-19 and self-amplifying RNA vaccines. And it's really, you know, I want to focus less about COVID-19 and really about the technology, the self-amplifying RNA vaccine. And really, this is a journey that not just me and my team and several other teams we took sort of together in developing a COVID-19 candidate, self-amplifying RNA candidate, and the lessons we learned as we went through it. Okay. Just an introductory slide, and here what I really want to highlight is that these are sort of the leading approved licensed vaccines for COVID. As you can see, these are where they're being used. And you know, if you look at this legend here, there's COVID-19 vaccines of various platforms approved and being used, right? A lot of the inactivated vaccines are here, the adenoviral vaccines, a lot of which are used in India, a lot of which are used where I'm from in Sri Lanka, also in Singapore. So in Singapore, we use, where I'm currently based, we use the RNA vaccine. So that's where I want to highlight, because of this pandemic and the need for vaccines, it really pushed the vaccinology field as well forward. And, you know, we were lucky to really get these RNA vaccines approved, which had never been approved and used in humans to this scale before. And that really brings me to RNA vaccine technologies. And the ones we hear about, the BioNTech, Pfizer, and the Moderna ones, is really using the conventional mRNA technology. And that is basically you have your mRNA transcript, and that encodes for whatever immunogen you want to put into it. So in case of COVID-19, usually that's the spike protein, right? And then when you inject that into a person, there's translation and you get that immunogen of interest. Now, the other more newer form of that RNA technology is a self-amplifying RNA, and that's what I'll be talking to you about today. And how this is different is the RNA transcript that you inject a person with actually has a viral replicase right before the immunogen of interest. So what happens when you inject this into a person is that initially this viral replicase, which is an RDRP, so it's an RNA-dependent RNA polymerase, that'll amplify your RNA of interest encoding your immunogen. And then that gets translated. So you can see how a self-amplifying RNA, it amplifies the signal and basically amplifies the immunogen. And another form of this amplifying RNA is what's known as the trans-amplifying RNA. And that's where you still have that replicase, but that replicase, viral replicase, is on a different strand to the mRNA that encodes for the immunogen of interest. And there are advantages and disadvantages to this. And the advantage is that, in the self-amplifying RNA construct, this RNA is limited by the length of the RNA, right? If you have a big immunogen like spike is a huge protein, you also need to have the viral replicase ahead of it. So then this becomes a very long mRNA. And so you're limited, you can't put many other immunogens in here, antigens. But the trans-amplifying, you can put several other different mRNA transcripts. The disadvantage actually is you can't guarantee that what you're injecting, that every cell will get pretty much the replicase accompanied with your other RNA transcripts. So each one of these technologies use lipid nanoparticles. So the RNA is really embedded in these lipid nanoparticles, right? And these lipid nanoparticles really help to protect the RNA. It also has some adjuvanting effects. And if we look at really the history of RNA vaccine development, one of the things that made RNA vaccines successful is really this lipid nanoparticle. How do you get a piece of RNA into a person without it being degraded, right? And this lipid nanoparticle really helped us do that. And so each one of these technologies use these lipid nanoparticles. Now, as I mentioned earlier, the Pfizer's, the BioNTech, they're these conventional mRNAs. Self-amplifying RNA, so there was a candidate from Imperial College, and we at Duke NUS worked with Arcturus Therapeutics. And the trans-amplifying, there was one that BioNTech was trying to develop. But for some reason or another, BioNTech definitely, it wasn't immunogenic enough, and Imperial also dropped it. And as we go on through the presentation, you realize why currently there isn't really a licensed self-amplifying RNA yet. So I'll take you through this. Okay, so the first is RNA technology and immunogen expression. And as I mentioned, this is really collaborative work we did with Arcturus Therapeutics. It's a San Diego-based company. And their LNP is really proprietary pH-sensitive system that they call the LUNA technology. So one of the first things we asked was, okay, the self-amplifying system, it's really supposed to give prolonged and higher amount of protein expression of our immunogen, right? We wanted to see that in vivo. So the company, so this is what the company did on their side. They made two constructs, one self-amplifying with a luciferase gene, and the other one, a conventional mRNA, again with the luciferase gene. Then the immunized mice, so BALB/c with PBS control, mRNA with a luciferase gene, and self-amplifying with a luciferase gene. And just let me step back a little bit. The replicase that we tend to use, that we use, and also many groups tend to use, is the Venezuelan equine encephalitis virus replicase. So that's an alpha virus replicase. So what we initially did was we injected into the mice, and we sort of tracked the luciferase signal to see which construct is making the most amount of immunogen expression, protein expression. And it's a bit of a no-brainer, and we can see definitely at each one of these doses that we tested, so PBS has no real signal, but the mRNA there is, and very early on, the mRNA tends to give a higher signal, but over time, the self-amplifying signal really catches up and really exceeds. We only sadly went to day 7, but there is published data. So this is published data from the founder of BioNTech, Uyghur Sain. They published a paper in 2018 that pretty much showed just exactly what we showed, that using an mRNA construct and a self-amplifying, there's really a lot of protein expressed and also for longer in the self-amplifying construct compared to the mRNA. So then we designed with the company, we designed one for COVID, and there's a conventional one and there's a self-amplifying one. And really we encoded for the entire spike protein, and we did the full length, so that's including the transmembrane and the cytoplasmic region. And this is the native spike. So this doesn't have any of the pre-stabilization mutations. And just to, the nomenclature, as we went through the development, changed a little bit. So initially you'll see LunaCov19 for the self-amplifying, then you'll see ARC-021, but these are all self-amplifying constructs, and it's the same. So initially we showed between mRNA and LunaCov19, or self-amplifying, there's really no difference in the LNP trapping, right? The amount of RNA trapped, the size of the LNP, it's all very similar. So there's no difference in the lipid nanoparticle. We also showed that because we put in this native spike, after, when you transfect cells, 24 hours later, you can look at the expressions. This is sort of like a Western blot. And you can see, obviously get full length, but you also get a lot of cleaved spike. And this is normal because our furin site has not been mutated. Okay, so the first thing we did was we looked at initial immune gene expression in the lymph node. And then we also looked at T cell responses. And here what we did was we took black 6 mice, injected them with PBS or mRNA or self-amplifying at 3 different concentrations. At day 7, these mice were sacrificed. This is sort of the optimum time to look at T cell responses in the spleen, which is why we did that. We also looked at gene expression in the lymph nodes to get an idea of what's happening that early in the lymph nodes. So just a bit of clinical information. So very early on, we realized, so our colleagues tracked the clinical scores for these mice and also the weights. And what you can see is these red lines are all the self-amplifying. The black one is a PBS and the blue one is the mRNA. And as you can see here, the self-amplifying has slightly higher clinical scores and loses a bit more weight. So clearly it is a bit more reactogenic. So that's in mice, and that's important to keep in mind as we continue in the story. So we also looked at lymph node weights, and you can see right away there's a dose dependency where the self-amplifying construct, really those animals end up having large lymph nodes, which means there's really a strong immune response happening there. So when we went to the level of the gene expression, right, what we could see was, I mean, the data is not as clear as we would have liked, but definitely as you go increase in dosage, you see a clear separation between the self-amplifying and the RNA constructs, meaning that as early as day 7, even the gene expression in the lymph nodes end up being different. And we sort of looked at the individual genes, right? So here, this is the self-amplifying compared to the mRNA at each of the doses for gene expression of the lymph nodes. And you can see there are clear genes like there are ones that show affinity maturation, indicate affinity maturation. There are ones that indicate B cell maturation, really things that are needed for a good immune response, and they're higher in the self-amplifying. So this was really encouraging to us, right? So we went on to look at the T cell responses in the spleen. And as I mentioned, the spike is a huge protein. So SARS-CoV-2 spike is gigantic. So my colleague who's a T cell specialist had to really make several pools to look at the responses against the spike. So he ended up having 4 pools that spanned the spike. But if you take all the data together, what you can see is that definitely the self-amplifying at all doses is giving a very large T cell response. And both constructs are, it's just the self-amplifying is higher. then if you go down to the level of the actual pools, you find that pool 2, which really spans the RBD and the NTD, and that's really, or the end of the NTD and the RBD, those are really what's targeted by these T cell responses. And that is actually known. So that fits in well with the literature. Okay, sorry. Now we come to the humoral responses. And I think a lot of us in vaccines, this is what we care about, the T cell response, cellular immunity as well, but we also care about the antibody responses. These are easy to measure. And here what we did was we immunized 2 different types of mice just to make sure we are seeing similar trends in different mouse models, both BLAC6 and BALB/c. And what you can see here is that we immunized them, gave them 1 dose and bled them over every 10 days. And really at day 30, because that's how long we tracked the BLAC6 mice for, we did additional, not just track the antibody amounts, we also did things like avidity and also neutralization. Okay, so it's interesting, right? Before I go into the data, we asked ourselves, okay, we have a technology that ends up giving more immunogen, and it's also persisting for longer. How would this really affect our humoral responses? And there's information known about what this kind of thing would end up affecting. So definitely, this is again Uyghur's Sahin's paper from 2018, and he hypothesized that having more immunogen would leading to eliciting more antibodies. That's one something we already know. Then the second hypothesis is, and we've seen this in literature, is having prolonged protein expression. So having proteins expressed for longer in your germinal centers will lead to higher affinity maturation, right? It'll be retained there for longer, and that really leads to higher affinity maturation. And the third one is, if you have prolonged immunogen in your germinal centers and also a large amount, you might actually select for more BCR diversity. So clones of a diverse population of B cell clones, right? And so we sort of tried to get at these questions. Are we seeing the same thing when we compare our self-amplifying versus our mRNA? Okay, so we just ran, so for the IgG assays, the binding assays, we've been running Luminex assays instead of ELISAs, mainly because it uses up a less immunogen. And at the beginning of COVID, access to immunogen was an issue. So we've been using that. Then, as you can see here, it was very obvious what was happening at each. So here, this is IgG levels as MFI. So really at 1 dilution, we track the MFI using Luminex, and you can see PBS is pretty flat. Over time, mRNA is at low doses, there's barely a response. And as you go up, then you get more and more of a response. And then for self-amplifying, you really see responses even at the lowest doses. And this is clearly higher and take a long time to come down as well. So to get past that effector time period. Then even in the BLAC6, so this is the BLAC6 mice, and we see a very similar trend. Even though we tracked it for shorter, we really see a much higher binding IgG response. Then we asked ourselves, okay, what about the strength of binding, right? Are these self-amplifying RNA vaccines are eliciting more antibodies, but are they binding better? Oh, apologies. There's one more piece of data. The more antibodies, it was not only against the whole spike, it was also against each of the regions. So it's not that the self-amplifying was skewing the antibodies to different parts of the protein. It was really at each domain S1, S2, RBD, the self-amplifying was generating just far more antibodies. Same in the BLAC6, we see similar trends between the mouse models. Okay, so then we wanted to look at the strength of binding, and we did a very simple avidity, IgG avidity assay, where we washed the beads with urea. So urea really breaks those, it's a chemotropic agent. It breaks weak bonds, weak bindings. So then we could see right away that just after one dose, right, at day 30, the self-amplifying is not only producing more antibodies, but actually it is binding better. So the avidity is higher. Both mouse models showed that, definitely in the higher doses. So we went on to look at the neutralization because this is really the key functional endpoint that most people look at, right? And we did the PRNT assay to do that. And what we found was that, again, in both mouse models, we see a very large, much higher neutralizing capacity in the self-amplifying in both mouse models. And this goes along with our binding data. Then we also wanted to look at the quality, right, of the antibodies. So we graphed our neutralization on our y-axis, our amount of antibody on the x-axis. And what we could see was that at the high doses for the mRNA, they are producing almost as much as the self-amplifying. It's just that that antibody is somehow not neutralizing. So even the quality of response in self-amplifying was higher. Okay, so we come back to the slide, right? Did we produce more antibodies in self-amplifying? Yes, it did. So more immunogen led to more antibodies. Did it lead to higher affinity maturation? Now, IgG avidity, the strength of binding, is sort of an outcome of affinity maturation. So yes, we sort of did see that maybe there is higher affinity maturation. Now, what about BCR diversity? And the most common way to look at BCR diversity and also affinity maturation actually is to sequence out the BCR genes. But at the time, we hadn't really collected and sorted the BCR. We were sort of in a hurry to develop the vaccine. So we didn't have those. So we ended up using another technology and looking at antibody epitope diversity. And this is where we are. And this is really a technology that we collaborate with Linfa Wang's lab for. So Linfa, who's presenting next, this is really a close collaboration with his lab, and this technology is really in his lab, set up in his lab. And what it does is really use so we take a genome or a protein. So in this case, it would be a spike protein, and make overlapping tiles out of it. And so these are peptide tiles, longer than simple peptides, and then basically clone them into T7 phages. And so these phages will express these different peptides. Then we incubate it with the serum, use protein AG beads to pull them down and wash the beads. So whatever's not bound will wash away. And whatever phages are bound to antibodies, those phages will be pulled down, and those are sequenced out. So we know what epitopes are targeted by polyclonal response. And this is a library created by Professor Linfa Wang's lab and his team. And the data I show you really does a rich set of data here, but I'm not going to show you all that. But what I will show you is the portion of data that we got out of the SARS-CoV-2 peptides. And it's really it answers our question. So if I can bring you here, we compared the day 0, so whatever background we saw at baseline, to day 40 responses, right, after one dose. And what you can see here, obviously, PBS, there's no positive hits. So this on the y-axis is the different types of epitopes that came up positive. And then at 2 micrograms, so we dropped the 0.2 microgram just because there was barely any response in the mRNA at 0.2. And we just focus at 2 and 10. And you can see clearly there's a much higher epitope diversity. So not only is a self-amplifying producing more antibodies, it's also targeting more regions on the spike or the protein. And that's really what we see here. And then if we go sort of map those peptides onto the structure, you can see, so These pink regions are where both the mRNA and the self-amplifying are targeting antibodies, and the red is the only self-amplifying. And you can see here clearly there are regions where both are targeting, right, on the RBD. So this is really the receptor binding motif region that the human ACE2 binds. But then there are also regions that are just targeted by self-amplifying, and that region is larger. You can see so there's even on this top, which is the RBD region, there are more epitopes for self-amplifying. Same with the NTD. So those of you who are not used to looking at these structures, this region is the NTD region. And again, there are regions that are commonly targeted by both, but then there are also regions where the antibodies, the self-amplifying immunized mice are targeting. And the same goes to the S2. So apologies. So the same goes to the S2. You can see here, especially this flexible region is targeted by both. This is really an immunodominant linear epitope, and that is published in literatures. It's a lot of it is above even 1,000. And for us, we pretty much didn't even meet a single T-cell response above 1,000. So definitely our T-cell responses are lower. We had them, but they were lower. So then we looked at the antibody responses, and we were hoping the antibody responses would be very, very high. And we can see here after one dose, you can see a nice increase in antibody responses. Again, this was done using our Luminex system, so it's not directly comparable to what we see from published Pfizer data. Then we can see here as well, after the 2 dose, there's even higher response. Then older individuals, unlike the T-cell data where the cellular immunity, they tend to have lower cellular immunity, the antibody response is actually sort of on par, maybe only slightly lower, but even older people are producing a decent antibody response. This is binding antibodies. So then we went on, so then we compared against convalescent COVID patients. And this is where we sort of started getting disappointed. And what you can see here is that the titers in our assay for the convalescent is very, very high. So we are not making antibodies that are higher than what people are getting from infection. Then we went on to neutralization, and this is PRNT50s. And you can see people are making neutralizing antibodies. It's just they are waning faster. The 5 microgram is probably the highest after 2 doses. But if you compare it to BioNTech data, so this is the 30 microgram is what they're giving to people right now. And this D35 is probably equivalent to what microgram dose we went ahead with, which probably 43. You can see the GMT, the geometric mean titer, is above 400, and clearly we're not reaching those levels. So our vaccine didn't elicit very strong antibody responses, neutralizing responses. This was really disappointing, but not so surprisingly, actually, Imperial published their data not so long ago, and they saw something very similar, both in terms of binding antibody and neutralizing antibodies. They didn't have very high neutralizing antibodies either, and not all of their participants seroconverted by binding antibody and neutralizing antibody. And unfortunately, this vaccine was deemed a failed candidate and dropped. So it was kind of disappointing. But since since we're in academia, we wanted to ask ourselves what was happening. And we looked into, again, this work came far after the clinical trial because there was just no time during the clinical trial to ask these questions. But afterwards, we wanted to ask, okay, what's happening very early on after vaccination? Is the innate response just too strong? Is it swamping out the input RNA? So we did this study where people were given placebo or the self-amplifying, and they were bled at day 2, 3, and 8, and we did gene expression. And you can see at day 2, in terms of differentially expressed genes, there's a clear increased dose response, right? You can see that in the young. You can also see a clear response in the old. So that's day 2. And it's interesting because day 3 and 8, so by 7 days after vaccination, the differentially expressed genes in the blood, so this is blood transcriptomics, is really coming back down. And it is again at the level of the placebo. So this is very interesting. After 7 days, you don't see differences in transcriptomics in the blood. Then we looked at the enriched pathways. And I'm just highlighting the 1-dose data here for all young and old, just to make it easier. And this is increase in dose. And as you can see, as you increase in dose, there are signatures that pop up that correspond to inflammatory and TLR. There are also signatures that light up that are antiviral genes. And this sort of makes sense because we are giving mRNA. There is a double-stranded RNA step in our vaccine as well. So this makes sense. Now, unfortunately, at the time, we hadn't had the data to compare against what's happening in Pfizer. But currently my colleagues are doing that. And what they do say is that some of these genes are so the Pfizer mRNA, there is an increase in some of these innate antiviral and inflammatory genes, just not to the level as the self-amplifying. Again, I can't show you that data because we're currently doing it at the moment. So one of the questions was the early transcriptomics. The other question that we had was, can we improve our immunogen? And the reason we ask is a lot of people used the pre-stabilized construct, and we use the native construct. So the native trimer spike actually can fall off. It's not very stable. So we thought maybe we use the pre-stabilized one where there's sufficient data that it actually improves immunogenicity and also mutates the furin cleavage site. And we went back into mice. So after pushing this through for months and months and months, over a year, we had to go back into mice, back to the basics really, and try to improve our immunogen. And that's really what we did here. And we compared against, really we had again the native spike as before, we had the pre-stabilized construct, we had pre-stabilized with the furin cleavage site mutated, so it no longer separates into S1 and S2. And we tested 2 different types of mutations. And as we saw, not so surprisingly, is that pre-stabilizing and mutating the furin cleavage site actually does increase the binding antibodies in mice. It also, this is again spike, whole spike, and you can see that increase is seen across to different parts of the protein. This is the key point, neutralization. It also increases neutralization. And there's similar work that was done for SARS, the first SARS and MERS by Barney Graham's lab, other groups that had shown that pre-stabilizing and mutating the furin cleavage site would improve in antibody responses. And really that is what we saw, really very large increase in neutralizing responses. And when we again, this is work done with Professor Lin Wang's lab. When we tracked it across the variants, it still stayed strong against the variants. It's not as sensitive either. So, we went back to humans. Unfortunately, the ARCT-021 that we worked on for a long time, which was the native spike Wuhan candidate, was discontinued because it really lacked neutralizing responses in humans and was not worth continuing, right? Now there are second generation self-amplifying candidates that are pursued both by Imperial, but also by Arcturus, the company that we're working with. And they are pursuing it with the 5 microgram dose for the Arcturus company. And this is being given as a booster vaccine. So both Imperial and Arcturus are pursuing the self-amplifying candidates against COVID as a booster vaccine. And the way they changed it, at least for the Arcturus one, is they pre-stabilized it. Furin cleavage mutated it, so the furin site is mutated, and there's the 614G mutation on one. The other one was made with, again, pre-stabilized and mutated with the Delta variants, because at the time they were being constructed, Delta was the one circulating. And this is neutralizing data from humans. So humans, as more and more people across the world are they're already immunized by some vaccine or another, right? And they need boosters, especially against Omicron. What we did is, both in Singapore and elsewhere, is after 6 months of 2 doses of the mRNA Pfizer BioNTech, they ended up immunizing with either one of these constructs and did neutralization against the Omicron variant. And what we found was that, unlike earlier, so this can't be compared head to head with the results we got from ARC-021, right, the full length. But what's promising is that as a booster vaccine, they see gigantic increases, fold increases in neutralizing response. So, I mean, there seems to be a clear path, at least as a booster vaccine for self-amplifying RNA vaccines. Imperial is doing the same with their self-amplifying RNA vaccine candidate. That really brings me to the conclusion. And so in mice, these vaccine constructs did really well. Self-amplifying constructs did really well in mice, both our construct and the Imperial College construct. We do know there are differences in innate immune pathogen recognition receptors between mice and humans. But again, in mice, they did really well. In humans, they were safe, but they didn't induce very strong, potent neutralizing antibodies. However, this may be, it's possible it's due to the immunogen, and that is what the second generation vaccines are doing. They're changing their immunogen to match the variants, but they're also improving it with pre-stabilization and so on, and using it as a booster vaccine. But we did see an indication that the innate response for the self-amplifying might be highly inflammatory, or there are antiviral genes that are elicited, that maybe this is swamping signal. We're not sure. This needs much more work to be done. Now, the issue with thinking that the pre-stabilization and the immunogen design alone is explaining the low immunogenicity of our ARC-021 that we tested, is that actually the Imperial candidate, the self-amplifying candidate, their construct was pre-stabilized. And that didn't do as well in terms of neutralizing antibodies. So really, we think there may be other explanations to why the initial construct failed. And I think that really does open our eyes to the fact that we need to do more research on amplifying RNA vaccine platforms. There's hope there, but it needs a lot more basic research in terms of how this platform works and can be applied. And definitely that kind of research, we found out we can't do it during the pandemic. The pandemic, the only thing we could really do is push a vaccine through. Now that there are vaccines available, licensed ones that are working, we can now come back to the science and really try to improve the platform, not just against COVID, but also against other pathogens that pop up in the future. And this is sort of my last slide. I just want to thank all these people. This was a huge group effort. Clearly, plenty of people so the viremics group, that's us, we did a lot of the translational work. Then the groups that did the clinical trial, the CROs, then my big PIs group that did a lot of the mouse work and supported work. The company that really did the development, basically a lot of other groups that helped with this this endeavor. Linfa Wang's group really provided a lot of that epitope mapping and variants of concern neutralization work. And really, this is really a group effort. And this was really led by my two bosses, which is Professor Enyong Wee and Dr. Jenny Low. So those are the two PIs that led this whole sort of endeavor along with the Arcturus leadership team. Thank you. And any questions?
Thank you, Ruki, for that excellent, wonderful lecture.
No problem.
Yeah, we have really enjoyed listening to you. Your pioneering efforts to make a self-amplifying RNA vaccine. I'm sure that there will be a lot of doubts in the minds of the people who have been listening to you. One thing is that when you are using an amplifying, self-amplifying RNA, what would be its fate, in the long run?
Right.
That will it go on replicating by itself and probably can't invite any mutations by which it can become hazardous. It can become hazardous to the individual wherein you have used it as an immunization measure. That's my first question. Maybe.
Okay.
The other one is that because it's a very targeted mechanism of immunization, I'm sure that it's going to make an impact. But will it work with all those mutations that is occurring in the COVID? That's
right.
what.
Right. So let me answer the first question. It's a great question. We don't know. And we don't know if there are mutations, right? Theoretically speaking, RDRs have error rates. So you're right. There are probably mutations in what comes out. I would think that's an advantage because it increases the diversity of the antibody pool that comes out. Now, the issue, it seems, in humans, and we haven't tested this thoroughly, is that we don't know how long this mRNA lasts. So the self-amplifying RNA, we don't know how long it lasts in humans. Our hunch is that it might be getting swept away by the innate response. That actually we might having the opposite problem. It's not lasting long enough, is what we think. That's for the first one. And the second question, you're correct. Will this platform be able to tackle all the variants of concern? We don't know. In mice, clearly, there's an increased breadth of
PINT. And then this is the CPAS, the commercial test now, the surrogate virus neutralization test. And as you can see, they correlate very well and has an R square of 0.95. And the other thing is very important is you have to be able to differentiate between what we call the binding antibody versus the functional neutralizing antibody. So this is another, a power of our assay, because what we did now is if you have the RBDs, the same receptor binding domain, here we have 4 monoclonal antibodies, all binds very well, especially that red one has the highest affinity to the SARS-CoV-2 RBD. But when we did this blocking assay, the surrogate virus neutralization assay, as you can see, only 2 of them neutralized, and the best map, the red one, actually failed to neutralize. So the assay is truly a functional assay. It measures the neutral antibody and can differentiate between the binding versus the neutral antibody. The other thing is very important is that, when you investigate a human outbreak like COVID-19, it's a zoonotic virus. We already know that it comes from animal and spill over to human. So that in order to, do the virus origin and then later we wanted to see the spill back kind of studies, then ideally you want the same assay. So what we want to demonstrate is the surrogate virus neutralization can be used for different animals in a species independent way. So here we demonstrate just the rabbit versus mouse data. But since we commercialized the kit and through research collaboration, this has been used for more than 20 different animal species. And the important ones are the mink and the white-tailed deer I will talk about later. And for COVID-19, everything happened very fast, and I'm joking about this COVID speed. So we start this scientific concept late February, and we order reagent, and we have a proof concept, we patent it, we published the paper, we went through a commercial company, we go through regulatory approval, and we launched the product as a commercial kit called CPAS on May 15th. So all this was done within 70 days. We're very proud of this. And not only that, and this test eventually got approved by the US FDA, become the first test that can detect neutralizing antibodies, for SARS-CoV-2. So now, after the emergence of the variants of concerns, we have moved a step further. We have transformed this single test. Remember, that was the one test for the SARS-CoV-2, the ancestral virus, the Wuhan strain. With the VOCs, we have the needs to really, provide and beta has 3 and Omicron has 15. And so you can argue Omicron has the most, mutations in terms of the virus that you can derive the variant from human. But in bats and pangolins, we know this clade 2 virus already exists. And some of them have very, excuse me. And some of them already have really lots of a large number of mutations. The bat virus has 22 and the pangolin virus has 30. So just keep in mind that the Omicron has 15 amino acid change, and the next one has 22 and next one has 30. So now if the virus ability to escape the neutral antibodies of SARS-CoV-2 purely as a function of the number of the mutations, then you should see the gradient, right? The more mutations, the more escaping. However, when we did this study, it's not the case. So as you can see that, so this is just NT50 of all the 20 panel zero, we take the medium average, right? So they neutralize the ancestral virus the best, Delta next, and then the bat rat G13 with 22 amino acid change next, and then the pangolin virus with 30 amino acid changes here, and Omicron with 15 amino acid change is the most potent in escaping the mutant. And then of course SARS-1, because it's in a different clade, it's like a different serotype, you know, and it has 60 mutations. So SARS-1, of course, is the least. So these three viruses are interesting. They are all SARS-2 related, and Omicron 15, and this is 22, and this 30. So the other thing is you look at this serum, we use 2 doses of mRNA, 3 doses of mRNA, and this is a vaccine followed by infection, and this is SARS-1 followed by vaccination. So we have did a 2 plots. So this is a neutralization reduction as a function of number of mutations. The solid line is what we call the pre-emergent or the animal viruses that has not seen human immune system, is not under human selective pressure. The dotted line is the VOC, the variants of concern. So 2 things. One is if you look at the solid line, the slope here versus slope here, is that when your neutralizing antibody gets level is high or broader, and then the drop is slower. So that's number 1. Number 2 is you look at the solid line versus the dotted line drops much more faster. So what that means is the variants of concern evolve in our human population already with pre-existing immunity against SARS-CoV-2. So these viruses are more potent in escaping this immunity. So now I change the topic to spear over and a spear back, right? So that spear over and spear back is also, you have the forward zoonotic transmission, that means animal to human, and the reverse zoonotic transmission is human to animals. From the 6 viruses as described, Hendra, Nipah, SARS-1, MERS, you know, SARS-2, Ebola, it's the first time for SARS-2 we had to worry about that. In the previous viruses, either, you know, they don't spread very far or they're unable to spear back. But for SARS-CoV-2, we have many examples already. So now really the roles of wildlife animals in emerging infectious disease events has been expanded, right? In the past, traditionally we think of a natural reservoir, intermediate host, and amplifier host. But now with SARS-CoV-2, they can also be a spearback host. And this new terminology I call this unnatural natural reservoir. So in the nature, the virus could not reach them, but with the human beings, now we have how many hundreds, millions of people, you know, infected, that we pass the virus to animals all over the world. So what we have now is the scenario, right? We still believe that SARS-CoV-2 emerged from bats, most likely in Asia, goes through animal X and to human, followed massive by human to human transmission all over the world and still ongoing. During that process, there's many chance for human to spear back to animals, and the mink was the first one caught the world attention. Virus evolved and spear over again to humans. So we already know mink has variants and can pass back to human. So that's kind of bad, but it's not the worst, because if you pass the animal to farm animals like a human pass the virus to farm animals like a mink, at least, and also the mink got sick, right? So you can detect the content. What happens if you pass the virus to a wildlife animal, and wildlife animal like bats usually are resistant to disease? So they become this unnatural natural reservoir, and the virus keep mutating. And then over the years, they will go through animal X and Y, Z, and through humans, spear over again. And that could be SARS-CoV-3. So, you know, 2 years ago, we worried about that, and we published a review in PLOS Pathogen in 2020. But now it's a reality. You know, for those of you who have been following this in the USA, you know, the white-tailed deer, you know, so it's a wildlife, but they live very close to, you know, human beings. And there are lots of white-tailed deers, I can tell you. So now multiple studies basically found that there's a high prevalence by serology that goes to 40 to 80%. Some population has this virus already circulating. Very, very concerned is that they have very high infect rates as indicated by PCR and the serology. And personally, I'm very, very proud because our CPAS assay, remember I developed this in a species independent fashion, so that you can use for animal studies as well. So CPAS already play a role in this study. The other is that we already found that multiple lineages that are in this deer population, means the spear back from human to animals to deer happened more than once. And this virus or these animals can carry the virus asymptomatically, so fulfill this natural reservoir kind of phenotype. So this is something that you need to watch, because the virus will mutate there, and then a new variant will come back to human. So the current vaccines, are they good enough? Obviously not, right? You know, we are just, no matter whether you got 3 or 4, even 4 doses of vaccine, or if you have been infected previously, you can still be infected. The reason is 2. One is the longevity of the immunity is not as long as we want, but more importantly is the immune invasion. I already told you, right? The Omicron, for example. So as early as last year, almost a year ago, you know, John Cohen, so it's a very well-known reporter for Science. He already wrote this kind of feature article to say we need a dream vaccine because the current vaccine is not good enough. So then I said, dream comes in different generations, you know. So in mobile phones, we're used to first generation mobile, we have 1G, 2G, 5G. We're onto 5G and developing to 6G. For COVID-19 vaccine, I think we have to go through the same evolution, right? So this is the same coronavirus family tree I have shown you before. But the vaccine we have, you have, I have, is first generation 1G COVAX. Because all the vaccines were based on the SARS-CoV-2, the ancestral virus from Wuhan. I mean, you have read and heard from the news, you know, companies have developed the 2G vaccines based on initially Beta, then Delta, and then now Omicron. But none of them is commercialized for 2 reasons. One is that you just, you know, not fast enough to catch with the variants. And secondly, as I told you already, Delta is more distant related to Beta than to the original ancestral virus. So if you have a vaccine against Beta, it's actually is going to be less potent than Delta, than the first generation vaccine. Same for Omicron. So where is the end, right? So our group is aiming for the 3rd generation vaccine we call 3G COVAX, is trying to develop a vaccine strategy can protect against all the Sarbecovirus. And so hopefully we don't have to worry about variants or even SARS-CoV-3. And then there's a 4th generation, which covers all the Beta coronavirus. And then there are scientists very ambitious, want to go to 5G and cover the whole coronavirus family. So middle last year, we published this paper in the England Journal of Medicine. We found that in Singapore, a cohort that the SARS survivors in Singapore, they infected with SARS and survived in 2003. And in 2021, you know, they got the vaccine for Pfizer. And we found that in their blood, we found this dream vaccine, a dream antibody we call the pan-Sarbecovirus neutralizing antibody. Very, very potent. They got boosted against not only SARS-1, SARS-2, but against all different Sarbecoviruses. So what's happening, we think, is that, you know, our immune system is very smart. If you get a SARS infection or SARS vaccine, they target the immunodominant epitope. I demonstrate by the circle. And then if you come to SARS-CoV-2, the immunodominant is a triangle. And triangular circles are not overlapping. What we want is the non-immunodominant but highly conserved neutralizing epitope. You know, these are the cross neutralizing, we call cross-clade. So we kind of discovered in the SARS survivors when they give them the COVID-19 vaccine, and then they get these really good cross-neutralizing, you know, antibodies. Okay, so I'm going to play a video because the New England Journal of Medicine not only published a paper that they produce animation. I think that this is much better than I can explain. So I will show you this for 2 minutes.
SARS-CoV-1 and SARS-CoV-2 belong to the species SARS-related coronavirus and the subgenus Sarbecovirus, but are in 2 distinct phylogenetic clades. Emerging SARS-CoV-2 variants pose a challenge to the effectiveness of current vaccines. A vaccine capable of controlling current SARS-CoV-2 variants of concern, as well as preventing infection by other Sarbecoviruses, would be optimal. To investigate the possibility of cross-clade boosting of neutralizing antibodies against Sarbecoviruses, investigators obtained serum specimens from 8 long-term survivors of SARS-CoV-1 infection who had received the Pfizer-BioNTech mRNA SARS-CoV-2 vaccine. Surrogate virus neutralization tests were performed to analyze the specimens for neutralizing antibodies against 10 different Sarbecoviruses, 7 from the SARS-CoV-2 clade and 3 from the SARS-CoV-1 clade, including variants that affect only animals. The authors examined 5 serum panels consisting of specimens from unvaccinated SARS-CoV-1 infection survivors, unvaccinated patients with SARS-CoV-2 infection, healthy vaccinated persons, vaccinated survivors of SARS-CoV-2 infection, and vaccinated survivors of SARS-CoV-1 infection. All vaccinated survivors of SARS-CoV-1 infection had high levels of neutralizing antibodies against both SARS-CoV-1 and SARS-CoV-2, including several variants of concern. These patients were also the only group with a broad spectrum of neutralizing antibodies against all 10 sarbecoviruses, including bat and pangolin viruses with the potential to cause human infection. In this study, high levels of neutralizing antibodies against a broad range of sarbecoviruses, including both SARS-CoV-1 and SARS-CoV-2, were detected in survivors of SARS-CoV-1 infection who were immunized with a SARS-CoV-2 mRNA vaccine. Further study is required to see whether other combinations of antigenic stimulation from different sarbecoviruses might be able to elicit broad immunity to the entire subgenus. Full study results are available at nejm.org.
Yeah, so, it's a very impressive, and I think we're lucky because we can do this study other groups couldn't for 2 reasons. One is we had this a cohort in Singapore, the SARS survivors, and received the Pfizer vaccine. Secondly is, you can call it visionary, right? We were really already asking these questions, and we built up the very important tool, that multiplex surrogate virus neutralization test. So in this study is the 10 plex. In the paper we submit in the preprint is a 16 plex, and today we have gone this to 21 plex. Okay, so just to finish up, the dream is to have a pan-something vaccine, right? So number 1 dream is pan-flu vaccine, and the dream still continues, If we have a pan-flu, if anybody in the audience, are joking about if you can develop pan-flu vaccine, you deserve 2 Nobel Prize, I think. Pan-dengue vaccine, we also want. Pan-coronavirus vaccine. So I'm really sort of proposing a pan-sarbecovirus vaccine. But I have developed a vaccine, which is a pan-hannipavirus vaccine. So again, for those in the audience, in your state, this is very relevant. So the hannipaviruses, I basically kind of made my name. My first virus was a hannipavirus that I studied and I lead. Okay, so you have this bats to animals to humans. In Australia and the Philippines, the bats to horse to human. And then in Malaysia, Singapore, it's bats to pigs to human. And we believe in your region, India and Bangladesh, we think it's a direct bats to human transmission. But look at the case fatality mortality is all very, very high. So what we did in Australia before I left Australia, came to Singapore, is we developed this One Health approach vaccine. So what we say, in order to prevent the transmission and the disease in human, let's develop a vaccine in horses. So you're killing 2 birds with 1 stone. You protect these horses, especially in Australia. The first outbreak in Hendra happened in horses, racing horses. Each was like $500,000, Australian dollars. So if we can vaccinate a horse, we protect horse, but equally and more importantly, we prevent that transmission to human. And our dream, came true. So I approached the Pfizer Animal Health those days. Now it's Zoetis. So we had a vaccine and the license, and went to horses in 2012. And so far in Australia, none of the vaccinated horses has been infected with Hendra virus. So it's 100% efficacious in protection. But relevant to your region is this discovery we made. The same recombinant subunit vaccine, come from a Hendra virus, basically, was able to protect lethal Nipah challenge 100%. Now, this is for the virologists in the audience, this is my personal kind of experience, right? I have studied 2 classes of virus, the hannipavirus and the SARS-related coronavirus. Hendra and Nipah is around 80% identical, so different by 20%. SARS-1 and SARS-2 is similar. And yet, for hannipavirus, we have a vaccine that fully protects from Hendra to Nipah. And for SARS, we have a vaccine for SARS-2 could not even protect its variant like Delta and Omicron. So for the virologists in the audience, the lesson you learn from one family virus cannot be translated, without modification. So I just finish up to say that this is really important because the hantavirus soluble G vaccine we produced, licensed for horse use. Now the same antigen, of course, produced under GMP and with a human adjuvant, is being used as a shortcut to develop a Nipah virus vaccine, and is funded by one of the three projects CEPI is ongoing right now. Okay, so are we ready for SARS-3? So this is my kind of last, provocative question. And I would say, yes, science and technology, right? From SARS-1 to SARS-2, we have advanced so much, but unfortunately, we're still in the middle of SARS-CoV-2, and we did not do as well as we should. The reason for that is the geopolitics and legal framework. So we're not ready to fight another pandemic by SARS-CoV-3 if the geopolitics and the legal framework and the international collaboration does not improve. So with that, I'm going to thank my team. So this is the last happy party we had for Christmas of 2019. Ever since that, we were not allowed to, gather. So I always treasure the memory of our old happy days. And lots of collaborators. On the left is the Singapore collaborators. On the right is our international collaborators. And I use this opportunity to promote the two conferences I'm organizing. So this one I'm organizing with Sarah Gilbert, the scientist developed the AstraZeneca virus vaccine from Oxford, and William Darling and from CEPI. So this is a Keystone Symposium on emerging infectious disease. The theme is lessons from the pandemic, and it will be April 10th to 13th in Snowbird, Utah. And then the 7th World One Health Congress that I'm chairing, and this is 7th to November in Singapore. So I hope we can see many of you here in Singapore. Thank you. You're muted. I cannot hear you.
Oh, muted.
Okay.
Can you hear me?
Yes, I can now.
Okay, Professor Limpa, it was a wonderful talk. You have crossed through.
Sorry, lost your audio again. I cannot.
I don't know, maybe this Indian system. Can you hear me now?
Yes.
Okay. My point is that in 2018, Kerala had an outbreak of Nipah. You know that? And that was in a small pocket in the Malabar or the northern region of Kerala. We contained it. But there was a hue and cry that fruit bats were the culprits, as you said rightly. The bats are. And in the process, most of the bats were killed. That was part. The bats have become real enemies of human beings. Yeah. Now we don't look at them as friendly organisms. Yeah. So do you think for many of these viruses, the first repository of the virus is the bat, and then subsequently to other animals and so. And if so, why is it that bats become a favorite repository for all the kinds of viruses?
So there are two schools of thoughts, right? One is that to say all mammalian virus currently circulating in human and other animals most likely originate from bats for two reasons. That bats are the most successful ancient mammals. Bats overlapped with dinosaur, right? And dinosaur extinct, bats keep growing, okay? And then we also have the data, I don't have time to show you, is that bats have the right immune system. Their defense and tolerance is balanced. So they can co-live with virus much better than human or any other mammal, okay? So, but not every bats carry every viruses, right? We have over 1,000 species of bats distributed all over the world, okay? And so that right now, for sure, we know the very dangerous, the most deadly emergent viruses, including the hannipavirus, the filovirus, the coronavirus, reovirus, flavivirus, right, adenovirus, you know, and the pox virus, all of them have a huge abundance in bats. Bats are the most abundant reservoir. So I cannot declare that bats are the reservoir for every virus, but we can safely say bats are much better reservoir than any other mammal of the majority of the dangerous viruses. Why? Is what I said, because the unique biology of bats.
Okay, maybe that means we should not consider them as enemies for human beings. That's probably it's a natural course of evolution that they have become the hot place for placing all the viruses.
Yeah, so
maybe if you consider it that way, you will not become, consider them as enemies and try to kill them as much as possible.
Yeah, sorry, I could not really catch everything you said. Yeah.
Bats are not that dangerous organism, because the viruses find their place to be there safely without its immune system affecting on them, and then it is being transferred to other bats. That's what the concept is about.
Yeah, so this is it's to the benefits of virus, right? To be reside in a host that does not kill you, and also you don't induce disease in the host, right? So, and I always say it's not bats' fault. Bats has been on the earth much longer than human beings, right? So that, and also now what we're trying to say is bats also provide the lessons for us to learn about heart disease and autoimmune disease and the metabolic disease. They are just very healthy animals, yeah.
Yeah, you also said about the SARS-CoV-3.
Yeah.
So, are we going to have another wave with SARS-CoV-3? And if it is so, will they be much more dangerous than the COVID-2, COVID-1?
Well, I think, people are already discussing in the social media to say virus evolve in a human population. The direction, the only direction evolve is to be less dangerous for human, right? Then I said you have to actually, digest that statement. When you say less lethal to human, is that if it kills human at a high fatality, like Nipah virus, that it cannot transmit in human because you wipe out the human population. But now we're talking about virus that has a case fatality 1% versus 0.5%. From the virus evolution point of view, I think it makes no difference whether the virus has a fatality of 0.5% or 1%. But for human population, that's a twofold difference. So I think the chance is still there to have a virus that evolve, become more transmissible, slightly more virulent, okay, and does not really affect its widespread among human population. So I think, already we have example, right? We had Alpha variant first. Alpha was a little bit more transmissible, but not that more virulent. And then we had the Beta. Beta is not that more transmissible, but certainly much more potent in terms of virulence. And then we had a Delta, right? So the Delta is, less virulent, more transmissible. So even these VOCs was mutating all different directions. So it's not following the direction to say more transmissible and less virulent, okay. And for SARS-CoV-3, I'm not talking about SARS-CoV-3 as a virus evolving from the current SARS-CoV-1 variant. I'm talking about SARS-CoV-3 will be jump out the animal as a new virus and from this Sarbeco subgenus.
Okay. Do we think in the course of time that we will be able to develop a vaccine which would control or maybe immunize the population for the present non-viruses, SARS group of viruses, and the future ones which are going to emerge?
Yeah, so what I'm hoping is that my last, we developed this vaccine, So what we have a vaccine strategy, instead of booster with another COVID vaccine, SARS-CoV-2, we have engineered a new vaccine, which actually looks like SARS-CoV-1, okay? So now if you give this cross-clade boosting, then you generate a broad neutralizing protective immunity. That protective immunity will protect human population from future variants of SARS-CoV-2, but more than that, may also protect us from a SARS-CoV-3.
Okay, great. Are there any other questions? Okay. In that case, Professor Limpa, it was a wonderful talk. We are all very greatly impressed by the in-depth programs that you have for different groups of viruses, the vaccine program that you have in collaboration with different agencies. And I'm extremely happy that you would respond to our invitation and speak to us. Yeah. I'm sure on behalf of all of us sitting here, about 150 students sitting in front of the audience, and many who are out of time. We all benefited immensely by your great visionary talk. Thank you very much.
All right, thank you, thank you. Thank you again. Bye.
Thank you so much, sir, for your valuable information shared with us. All the participants are requested
Principal, Dr. Manoj, Dr. Dina, Dr. Ramesh Kumar, and my dear friends. It was an exciting day for all of us. The students sitting in front of me have benefited to the maximum. I'm sure that if you have gathered more information about the different aspects being deliberated today, I'm sure that you are the luckiest. Because none of information will not come from a single talk or a single lecture. 6 different people, experts from all over the world have talked. If you have got 20% of what is being transacted today, I'm sure that you are lucky enough because it's once in a lifetime event. You will never have this kind of gatherings. Maybe it becomes extremely difficult. And I tell you that it's a blessing in disguise that we are onto the online platform that we could gather all these people. Imagine that if you all invite all these people to Bellevue, imagine about the kind of amount we have to spend. We have not spent much. This is one way that we could manage this kind of programs. But I'm sure I congratulate all of you. I'm very happy because being a representative of a great organization, the Kerala Academy of Sciences, I haven't seen more than 30 people logging into this program. It's unfortunate. Unfortunate in the sense that people have a feeling that they know empirically. Even at this stage, I am in the layman's speak. I learn from people. I talk to people, and whatever I gather from them, I feel that they are unique information which otherwise is impossible to get. I don't want to prolong on because we are delayed too much, but I feel that this program has become so wonderful and so fruitful because of the great efforts taken by Bellevue College of Pharmacy. In mind sitting in front of me, the dedicated chairperson and the CEO and other people who have associated with this. And I'm so happy and excited that we could organize this program in this college. We will be, Kerala Academy of Sciences will be backing this college to the fullest extent because the cooperation and the facilitation that we are doing is definitely making us to open all the doors to you, not only through just facilitating your coming to the programs of Kerala Academy of Sciences or to the Kerala University or the institution I'm representing, the Central Laboratory for Instrumentation and Facilitation, but also to different groups of people all over the country and for you people to go and improve your country. So I take this opportunity to be able to contact us at any point of time, me or Dr. Ramesh Kumar or any of those people who have been sitting here. You can contact us and definitely we will try our best to help you the best possible. So thank you very much. I don't want to, because I cannot talk too much because this is the first time I'm moving out of Trivandrum city after a medical process. But I've talked enough and I'm tired. So, but I stand justified for having come to this place and choosing this place as the venue for this and choosing individually all these 6 great people from all over the world to talk to you. Thank you very much and wish you all.
For your valuable remarks to me. Now it's a time for distribution of certificates for the delegates who have attended all sessions of today's International Hybrid Seminar. For this, I would like to invite representatives from the part of delegates. A. Arya of ASM, page of ELPA. Please come forward. Sri Ahmed. Thank you, sir. Let me invite Dr. P. Manoj Kumar, Principal, the Delhi College of Pharmacy and Research Center for the validity address, as well as the vote of thanks.
Most respected Professor Dr. G.M. Nair, President, Kerala Academy of Sciences. Most respected General Secretary, Dr. K.B. Ramesh Kumar, other dignitaries on the dais and off the dais. It gives immense pleasure expressing the vote of thanks on the conclusion of today's International Hybrid Seminar. In fact, it was a dream come true for our institution, witnessing plethora of talks of such eminent scientists from outside our country as well as within our country from morning till now. At the outset, I express my heartfelt thanks on behalf of the institution as well as on my personal friend to Professor Dr. G.M. Nair sir, President, for giving our institution this great opportunity to be a part of hosting today's International Hybrid Seminar. Thank you very much. I thank Dr. K.B. Ramesh Kumar, General Secretary, for giving us all the confidence and all the support and good lot of guidance in coordinating this seminar in a great successful manner. Thank you, sir. I thank the Vice Chancellor, Central University of Kerala, Kasaragod, who was kind enough to accept the invitation to preside over today's inaugural function. I thank Upper Sri MC Dattan sir, Scientific Mentor to the Chief Minister of Kerala, who was kind enough to come to our institution and inaugurate today's function. We had a very versatile talk, very informative talk on the topic building towards pandemic preparedness. I express on behalf of our organization and Kerala Academy of Sciences for the keynote address given by Professor Dr. Gagandeep Khan, a very eminent scientist of international repute. We express our heartfelt thanks to Dr. Vinod Skaria, CSIR IGIB New Delhi, for giving immense information on the topic genomes from personal to populations and back. In fact, it was great listening to Dr. Shyam Sharma, Naipar Mohali, who elaborated on the topic cardiovascular safety assessment of COVID-19 drugs, focusing on ICH S7B and E14 guidelines. We express our wholehearted thanks to Dr. Shyam Sharma for his wonderful presentation. Dr. Anindya Bhatt, Sri Chitrathunal Institute of Medical Science Technology, Trivandrum, for a versatile talk on the topic 3D bioprinting, the promising technology in regenerative medicine. I am sure all our students would have been immensely benefited by the wonderful talk given by Dr. Anindya Bhatt on this topic. We all have been hearing for the past 2 years, in fact, about COVID-19, and certainly Dr. Ruklandi V. Alvis from Duke NUS Medical School, Singapore, gave us a lot of information on the topic COVID-19 and self-amplifying RNA vaccines. I'm sure those who are about to take up your higher studies would have already got an idea about where you have to proceed with the immense amount of information pondered by the speaker on this international hybrid seminar. I thank Dr. Ruklandi D. Alvis on this occasion. And as we all are aware, as the entire world is aware, we are afraid of bats. And as rightly pointed out by Dr. G.M. Nair sir, he also expressed the fact that we should not consider bats as enemies for us. And on this occasion, I thank Professor Dr. Lin Fawan, who was kind enough to accept the invitation of Kerala Academy of Sciences and deliver a wonderful talk on the topic bats, viruses, and COVID-19. I thank Honorable Speaker Professor Dr. Lin Fawan on this occasion. I take this opportunity to thank Dr. A.G. Raghu, Principal Scientist, CSIR, National Institute of Science and Technology, for joining us online on this auspicious occasion. I thank sir. Dr. P.V. Mohanan, Scientist, SCTI MST, for your gracious presence from morning till now. Thank you, sir. Dr. A.G. Pandurangan, former Director, JNTBGRI, for your valuable presence on this occasion, sir. Professor Dr. A. Annie Abraham, who was kind enough to be present on this occasion. I thank Madam in her absence. All the students who have put a lot of efforts in making this particular occasion a great success. Thanks to dear students. I thank all the colleagues of this institution who have put a lot of efforts for the great success of today's seminar. I thank the management and Dr. Sri Sajeev for being able to conduct the entire event where we felt that, as Sir had rightly pointed out, we had scientists from abroad also. And without this particular technology, maybe it's a part of the COVID-19 that we are able to attend these type of seminars which otherwise would have been impossible for us. I thank the technical assistance given by Mr. Sajeev, as well as the people who were working behind the audio and the sound system for making today's function a great success. Thank you, one and all.
Before concluding the session, let's all stand for the national anthem.
Jai